I'm going to go ahead and get started. Again, I want to thank you all for being here today. This has been about a year in the making. Christina has been super helpful in making this happen, but we could not do workshops without all of you. Our workshops are for you, so we really appreciate you taking time out of your day to be here. Like I said, anybody with a Jet Foundation shirt on, happy to help. I usually go around the room and do introductions. I'm gonna do it very short, so you don't have to be super loud. I think we can all pretty much hear each other. So the reason I do that is because so many of us don't know each other, and I wanna make sure that you are able to connect. Maybe you're in the same area, maybe you're not. But I'm gonna go around the room and we're gonna do name, where you're located, not necessarily where you're from, and then if you're here as a female with dystrophinopathy and don't have children, who you are, but if you have a child with Duchenne, what their age is, so that you can maybe connect with others, either further along in the journey, at the same stage of their journey, or maybe even a little bit behind in their journey. So I'm gonna go ahead, we'll have Pharma introduce themselves too. The clinicians, they don't know it, but they'll introduce themselves as well. So I will start over here. Yes. You can stand up or sit, whichever you choose.
I'm Amy Hart, and I'm a mom of a son with Duchenne.
And where are you from?
Oh, I'm from Waverly, Iowa.
Perfect. Back here. Mary.
I'm Mary Sanders. I'm married to a 20-year-old partner. He lives in Grant, and I live in Fort Wayne, so we're like 5 miles apart off of Mississippi. And I'm also a Jet ambassador,
She just wants to hear you guys. Of Duchenne. Awesome. Where should I go? Yes, perfect.
Hi, I'm Amber Grund, and we're in Grimes, Iowa. We have our son, Vincent, who's 14, who has Duchenne.
Yeah, and I'm Steve Grund. I'm Vincent's dad and Amber's husband in Grimes.
I'm going to say it. Yep. Vincent.
Thank you, Vincent.
Hi, I'm Michelle Norby, and my husband Michael will be joining me. And I'm from Greenfield, Iowa, and I have a 6-year-old with DMD. And I have an 11-year-old son, too, and he does not have DMD.
I am Amy Colwis. I'm from Colo, Iowa. I have Grayson, who is 11 with Duchenne, and my daughter, Callie, is 20, and she's a carrier.
I'm Monica Miller, and this is my husband, Derek. We're from Marengo, Iowa. We actually have 4 kids. We have Tatum, who is 13 with Duchenne, and then we actually have another son who doesn't have it, and we don't know about our girls yet.
Just go this way.
So this is Mohit, and we moved to US from India when we came to know about our son, Karthik. He is now 12-year old. At that time, he was 5-year-old in 2018, May 5th, when we came to know that he has Duchenne, and we decided to move to US. I work for Collins Aerospace.
Hi, I'm Karthik's mom. We live in Cedar Rapids, and Karthik is 12-year-old with Duchenne.
I'm Katie Miller. I am from South Dakota. My 9-year-old son, James, didn't come because we just had his appointments the other day. He has Duchenne, and he's got a 13-year-old sister and a 15-year-old brother, and his dad. And yeah.
Hi, I'm Lisa Simon. I'm Katie's mom. So I'm grandma to James, and we're from Illinois.
Hi, I'm Dave Simon from Illinois, and I'm James's grandfather.
I'm Taylor, and I'm in Marion. My nephew, who's 2, was diagnosed.
My name's Dylan. I have a 2-year-old with DMD.
My name is Liz. We're from Oquawka, Illinois. We have a 2-year-old son with DMD.
I'm Bill Lauk. I'm Liz's boyfriend from Oquawka, Illinois. Our son is 22 months old with Duchenne.
My name's Whitney, and we have an 11-year-old son with DMD, and I'm also a carrier, and we're from Cedar Rapids, Iowa.
And I'm Mary. I am Bentley's grandma, and we're from Cedar Rapids as well.
I'm Zach. I'm Bentley's dad, and we're from Cedar Rapids.
Zach, I like your shirt.
Thank you.
Hi, I'm Tom. I'm Bentley's grandpa from Cedar Rapids.
Hi, I'm Nikki Yankovic, and we are from Monticello. And our son is 13 with Duchenne, and our daughter's a carrier, I'm a carrier, and my mom's a carrier.
And I'm Russell Yankovic, and I'm Cooper's dad.
Brandon Borseth from Tipton, Iowa. Our son is 14, has Duchenne, and we also have twin 6-year-old daughters.
I'm Rose Borseth, and our twins are adopted, and I am a carrier.
Hi, my name is Evandro. This is my wife, Jules. We are parents of an 8-year-old child with Duchenne, and we live in Davenport, Iowa.
My name is Annette. We're from Cedar Rapids, and my 2-year-old has DMD.
Hello, my name is Katie Lopsher. I'm a physical therapist with the UI team here.
My name is Rachel Kin. I'm the pharmacist with the neurology team.
Chandra Miller. I'm a nurse practitioner for the group. I've seen a lot of the DMD carriers in clinic, and I'll be presenting on that later.
I'm Christina Trout, and I'm one of the nurses in the clinic.
Hi, I'm Dima Sadeh, and I'm one of the pediatric neurology neuromuscular physicians.
I'm Katie Lutz. I'm one of the other neuromuscular physicians.
Kathy Matthews, the final neuromuscular physician.
Jules, do you mind grabbing? And you can go ahead and start.
Oh, okay. I'm Jules. I am an advocacy person at ITF Therapeutics, and we have a approved product called Duvisat, or Givinostat, if you've heard of that. We're at the back table there. My colleague Justin is here, our medical science liaisons. If you have any questions or thoughts, we're here. Thanks. Justin's from Iowa, by the way, which is really cool. Somebody from the small town, he mentioned, he was like, that's my town.
Hi, I'm Terry Ellsworth, and I'm from Pittsburgh, Pennsylvania, and I work in patient advocacy with Regenix Bio. I'm an advocate, but probably most important, I'm also a Duchenne mom of a recently turned 24-year-old who an exon skipping pioneer.
Hi, my name's Joe Schneider. I work on the medical team at Regenix Bio. Happy to be here. I'm also from Minnesota, so nice to have being close to home.
Hello, everyone. I'm Alan Roloff. I work for Avidity Biosciences, and I am based in the Twin Cities. I am on the medical affairs team.
Hi, everybody. I'm Erica Escartine. I'm the head of the patient advocacy team at Avidity, and I live in Milford, Connecticut. Nice to see everybody.
Hi, everyone. My name is Alexander Lin. I'm from Wave Life Sciences, and I work on our medical affairs team. At our company, we develop exon-skipping oligonucleotides for Duchenne muscular dystrophy, and we use a unique drug designs, which I'll speak to later today, but thank you for this wonderful event.
Hi, everybody. My name is Rachel Titus. I'm with the patient affairs team at Sarepta Therapeutics, and I'm from the Boston area.
Hi, I'm Monique DeBoos, also with the Sarepta Patient Affairs team. We have 4 approved therapies for Duchenne, 3 exon skipping therapies, and 1 gene therapy, and I'll talk a little bit more about those later. And I'm based in Tampa, Florida, like Alexa.
Hi, I just wanted to say I'm Justin again. I'm with ITF Therapeutics. I'm an MSL, Burlington, Iowa area. That's where I'm from. So go Hawkeyes.
Hi, I'm Marie Brace. I'm with Catalyst Pharmaceuticals. I'm on the patient advocacy team, and we have a Gamry, also known as vamorolone, a steroid in Duchenne. I'm going to say I lived in Minnesota for 33 years, but I escaped about 3 years ago and moved to Arizona. I had to get out of the cold, so I feel like your old neighbor, but I'm not anymore, sorry.
Hi, I'm Jamie Johansson. I'm also with Catalyst. I'm a medical science liaison, and I am based in Michigan, so I have not gotten out of the cold yet.
Hi, I'm Amy Grover, and I'm part of the advocacy team along with Marie at Catalyst Pharmaceuticals, and I live in Southern California, so it's not too bad.
Hello, I am Latoya Martin. I am a patient engagement lead with NS Pharma, and I am out of Kansas City, Missouri.
Hi, my name's Tony Spear. I am also a patient engagement lead for NS Pharma, and I also was able to escape the cold from Maryland and just moved to Nevada 2 months ago. So.
Hi, my name is Amanda Christian. I'm with Heritage Specialty Pharmacy. I'm a community engagement manager and here to kind of showcase our vein viewer if you're interested.
Hi everyone, I'm Drew Scruggs. I'm with Edgewise Therapeutics. So we have a product for Becker and Duchenne muscular dystrophy, and I run our clinical trials, and I'm here with John.
Hi, my name is John Wing, head of medical affairs for Edgewise from Boston, which is also a cold weather area. So thank you.
Awesome. Thank you guys so much again. Like I said, I am Alexa Tinsley. I'm the director of programs for Jet Foundation. I am also from Tampa, Florida, so I'm remote. But Jet Foundation is based now in Norwell, Massachusetts. I'm going to go through and give you some more information about Jet Foundation. If you don't already know, I know as a lot of you walked in, you already do have a welcome packet, so I hope you know this information. But as I go through, if you do have any questions, please feel free to come find me. Happy to answer. Oh, Lisa, she did not introduce herself. She is from Illinois, and she has Ethan here, who is her grandson, and he is, how old now? 15, Mary already knows. And then Trina Stelly is our resource specialist who specializes in females with dystrophinopathy or carriers or manifesting carriers, or we're trying to still figure out the best language for that. So, and Trina is based in, I can't ever pronounce the city, but she is based out of Louisiana. All right, so here's the agenda for today. We have a jam-packed agenda with so much information. I'm very excited that we're going to be able to provide so much education today. So you do have agendas on your table, so I'm going to quickly go through this one. So Jet Foundation was founded in 2001 by Christine McSherry when her son was diagnosed at the age of 5. At that time, there were no therapies, there were no treatments available, so she really spearheaded the effort in terms of founding Jet Foundation to find treatments and cures. So when it was first started, Jet Foundation was primarily in research and funding research. And then after a while, Christine started to realize we needed to help families today and now. So we've shifted to direct service programming and educational programming like our family workshops today. So our mission is to empower families and individuals impacted by Duchenne muscular dystrophy through the development of transformative programming, educational opportunities, and ongoing support for every stage of a Duchenne journey. So one of the direct service programs that we have is our Camp Promise program. We have 7 locations across the country. It is similar to, if you've been to MDA Camp, it is similar to MDA Camp. However, what's unique about Camp Promise is there is no upper age limit. So you don't age out. I think our oldest camper was 46 last year. Camp Promise is one of our only direct service programs that is open to all neuromuscular disorders and not just Duchenne. So we have 3 kind of facets of that Camp Promise program. We have our on-the-ground Camp Promise program. So those locations are, I'm going to have to count on my fingers. We have Southern California, we have Arizona, Colorado, Ohio, South Carolina, Pennsylvania, and Washington. And then we do also have what we call a Camp Promise retreat. 3 of those locations are only for the 18+ community. So our Southern California, Arizona, and Ohio locations are you're only eligible to attend if you are over the age of 18. And then we also have Camp Promise Virtual Weekend, which is coming up May 23rd through 25th. That is a free program if you want to attend, if your children want to attend. It is over the weekend, and you're able to interact with others in a virtual setting. And then we also have monthly Connect programs. So we have trivia. We also have specifically 18+ hangouts virtually for the community to be able to connect as well. So if you want any information about that, you can either scan the QR code or please feel free to ask me any questions. So these are just some of the really cool activities we've done in the past. We've done hot air ballooning. There's a zip line at Rockies. So it's, all of our locations are accessible, and we try to do all of the things that we can do that are fun and accessible and safe. Fun and safe. Camp Promise is really one of my favorite programs, only because prior to being at Jet Foundation, I was a nurse in a hospital in Tampa, but then prior to that, I was actually a family care specialist for the MDA. So camp is near and dear to my heart, and this is a really great program, so if your children are interested, please let me know. And also, one of the things about Camp Promise is you don't have to be living in that location to attend. So some families like to vacation during the time that their children are at camp, so they'll come from other parts of the country and be a part of that. I know, Ethan has traveled from Illinois to Pennsylvania, so there's the opportunity for that as well. We also have our Jet Giving Fund, which is another direct service program that we have. This one is only open and eligible to those who have a Duchenne diagnosis. So we have 3 arms of that program. We have our Accessible Vehicle Fund. So that program is open once per year. It will open in October of this year again for our 2026 cohort. This is a fundraising program, so the families that are accepted into the program have to raise half or more of a vehicle, and then Jet Foundation will come in, provide the remaining funds, purchase the vehicle outright for a family. So we do have a lot of applications that come in, but we were able to select 16 families into our program this year. So it is an impactful program, it is a competitive program, but it is an option. And if for some reason you are looking for an accessible vehicle and you are not able to wait until October, please reach out, and I'm happy to give you resources on how you might be able to do so, and financial resources that might be able to help, and other Duchenne organizations that might be able to help before that time as well. We do have our emergency fund as well, so that is a year-round program. You can apply at any point during the year, but you can only be awarded once per year, but it's in that fiscal year. So say you applied in October and need emergency assistance in January of the next year, you could still apply in January. We do also have Jessica Campbell, who is our social worker at Jet Foundation. So she's the one reviewing those applications and connecting with families. So she's also able to provide resources outside of that emergency fund application in a time of need as well. So we can still try to find you resources, even if we aren't able to financially help you with that award in the future. And then we have our Equipment Assistance Fund. So this is financial assistance for small accessibility equipment that is either, well, actually, I don't know if small is the word I would use. We've helped with ceiling lifts and other things, but it is a max award of $2,500. And then we try to work with other organizations for those larger priced items to help families as well. So if you need equipment, please reach out and we'll see what we can do to help. So this is typically equipment that either isn't covered by insurance or the copay is too expensive for a family to be able to provide the funds for. So this is just a quote from one of our families that got a vehicle, I think it was 2 years ago, and then one of the families that we were able to help with our emergency fund program. We have our community ambassador program. Like I said, Lisa and Mary are both community ambassadors for Jet Foundation. Whenever we have someone who connects with us who needs support or hasn't maybe connected with another Duchenne family, we have community ambassadors throughout the country that we can connect them to, whether it's, again, area or stage in the journey or carrier or whatever they need support with at that time. We can connect them with ambassadors who have come into our program to help support others. And if you want to be an ambassador, please reach out to me. Please feel free to ask Mary, Lisa, whatever that may be, and we'd be happy to give you more information. We do have a community webinar series, so this was born in COVID, but is something that's really important. So we weren't able to do family workshops during COVID. So we started community webinars. We have these at least once a month to provide topics or knowledge on topics that we're hearing in the community. So if we're, for example, we have coming up on, so May 1st, we have Avidity. They'll be talking about their top line data. So they have a short presentation today, but they'll go further into that information on May 1st. And then we also have on May 8th, we've been getting a lot of questions about ABLE accounts. So we'll be doing a webinar on that, and you can watch that live, or it's also recorded. You can watch it after the fact and ask questions from there. And we also have a ton of recordings on our YouTube, and a lot of them are also on our Facebook to be able to answer some of those questions that you may have. So if you reach out and you have a question, we might have a webinar to be able to help provide some information for you. And we're also connected to physicians to be able to ask those questions if we may not be able to answer them. Family support groups. So we have 2 family support groups at this time. We have our Porch Night program, which is for moms and caregivers of children with Duchenne. So these may typically bi-weekly. We take a break in the summer, so in the spring and the fall. And it's just to support each other and talk about all of the things. It doesn't just have to be Duchenne related. We're just there. It's a community and a space to be open and honest and get support from other families that might understand what you're going through. And then we also have carrier conversations, which we have once a month. We switch off on Thursdays and Saturdays. Trina actually facilitates that support group. And it's the same thing, just talking about, things that you may need support with or may not be feeling heard or whatever it may be, coming into that conversation and getting supported in whatever way that you need. And if you want to learn more about that, please feel free to reach out to any of us here with a Jet shirt on. So ways to stay connected and get more information about webinars coming up or workshops coming up or anything like that. We're on Facebook, we're on Instagram. You can also sign up for our newsletter. If you've signed up for a welcome packet, you should be getting a newsletter at some point soon. But please feel free to follow us for more information. And as I said, we have our YouTube channel, which has all of our webinars. And we also do post the workshops, the educational pieces of the workshops on our YouTube for families to be able to go back and listen to, but also for families that weren't able to attend. And that is it from me. So I am going to go ahead and we're going to hand it off to our first presenter, which is Christina Trout. Oh, and there's breakfast will be out for about another 15 minutes, so if you want anything else, please feel free. Coffee will be throughout the day. Water will be throughout the day. We have bathrooms, so men's bathrooms, accessible bathrooms are on this side. I do not know what those look like because I cannot go in the men's bathroom, but hopefully there's room to move around. And then we have women's bathrooms, which are also accessible on the right side, pretty close.
Well, we'll see how this goes.
You do have a clicker.
Oh, I have a clicker, but I can't see the slides very well.
Okay. Front, back.
So I'm Christina, the nurse in the clinic, and I'll be just giving an overview of multidisciplinary care for Duchenne families. So this is a team approach. As you've seen already, we have a lot of our team here today. Primarily, we're from the core team, the neuromuscular clinic, but our team branches out into several different areas, including all of the subspecialties. So it's a team of healthcare professionals from different specialties collaborating to provide comprehensive and coordinated care. In DMD, we also work with the advocacy organizations like Chet Foundation, and we also work with research partners and industry who's developing medications, and then once those become FDA approved, they become an extension of our care team as well. There are many doctors, nurses, social workers, all kinds of therapists involved in our care center, and this is hoping to take into account not just the physical needs that families experience, but also the emotional well-being and their social needs. The goal is to provide the best healthcare outcomes, and it's personalized to you. Even though we follow the care guidelines, which are an overall recommendation for Duchenne, we do keep in mind that each family has individual needs, and we hope to reach out and meet those. The care considerations were first published in 2010. These are CDC-funded effort to bring specialists together to determine what is the best care that boys with Duchenne need. Those were updated in 2018, and you can tell by the name, these were called, commonly called care considerations rather than standards of care or care guidelines. That's partly because these are consensus recommendations. So there's not a lot of science that backs these recommendations. These are just what the experts thought would be beneficial in caring for someone. So these were updated in 2018, so we're already getting past the preferred, timeline in terms of are these outdated recommendations. So there's a supplemental group of papers that were published in pediatrics. This was an effort with the CDC and the American Academy of Pediatrics to further expound on some of the care consideration recommendations. So these go into more detail, so if you want to access those, you can read it. I gave the reference here. But even in that, it takes so long to get the experts together, come up with the recommendations. By the end of the process, there were already new and emerging therapies that were not addressed in those care guidelines. In addition to that, the care guidelines had added things like the importance of maintaining primary care, the importance of transitioning youth to adult health care providers or providers that will keep in pediatrics but provide more adult-like health care. The last part of this series of papers was an evaluation thinking about these are not science-based recommendations in all situations, but how are we going to go about evaluating whether or not these are actually improving the health of our individuals. Over time, I can tell you, Dr. Matthews and I just had our 35 years together at the university. We definitely see that care is improving the lives, the quality of life, as well as life expectancy in Duchenne. If we talk about all of the care guidelines all at once in every single appointment, it would not be a 4-hour appointment, not an 8-hour appointment, but multiple days. So we do our best to address those things that are most important at that time in your lives. Here I kind of put up each of the care guideline areas, including diagnostics and neurology, which is kind of our backbone and specialty. This is where you get your genetic diagnosis, and we talk about the role of muscle biopsy, which is generally not used outside of the research setting at this point. Some clinics, instead of having a neuromuscular doctor or a neurologist, they have a PM&R, that's physical medicine and rehabilitation provider, or they have both of those specialties, but there's a lot of overlap in that. We also have the physical therapist, occupational therapist, and many others that are addressing the rehabilitative needs and whether or not you might need equipment. Corticosteroids is one of the first conversations that you have in the clinic, of course, and at the time of the care guidelines, there was only 2 that were actually FDA approved. So now we have a third steroid to consider as well. Endocrinology is relatively new to the Duchenne space, and they deal with bone health, puberty, and growth. We also have psychosocial needs addressed through a variety of providers, including our social work psychologist. The nurses and the doctors all kind of take a part in that. And then, of course, cardiac, pulmonary, orthopedics, addressing contractures and scoliosis. And then at different times in life, we also bring in GI, speech, and nutrition. The care considerations, again, are a lot to consider all at once. That picture on the right in green is kind of a table that's dividing out what's needed at various ages. Obviously, there's a lot of overlap, and in general, you add more people and more services as time goes on. There is a family-friendly version of the care considerations. That's a picture of it there. It's available online through several of the advocacy organizations' links, and I have a few of them in clinic if that's something that somebody would want. In the care guidelines, they had a model of care that had the patient at the middle of the circle, and that they're surrounded by their family who facilitates what their needs are throughout the life. And that at some point you enter this circle, typically with neurology when you get your diagnosis, and that we continue to add all of these other services, and that we all surround you with the care that's needed. And at different points you might be interacting with these individuals at more intensity than others. And of course, it's not just a pediatric disorder. This is an adult disorder as well now. And so each of these services need to be added and continued throughout adolescence and into adult life. There are different models of care for comprehensive multidisciplinary care. Typically, most of those models have us as a same-day model, and that's kind of what's been promoted, is that you see all of these different services on the same day. There are slight differences between how clinics do that. We typically start with neurology and start adding specialists in over time. And others do it where you start at the very beginning of your first appointments. You see all of these specialists for no other reason to introduce themselves. I see some concern with that because I think it's really important that you focus on what's most important at those appointments. And I think they can be exhausting, and you should take into consideration what your needs are at the time. At the same time, though, if you're meeting people in advance of having those needs, there can be some value in knowing what to expect and plan ahead. Let's see here. One of the things that the care considerations do not take into consideration is that many of you participate in clinical trials, and we do make an effort to try to coordinate your care to have the least amount of burden to you making travel arrangements and having to come for extra appointments. But typically, participation in a clinical trial is an additional set of appointments outside of your clinical care. And research appointments do not address your health needs. Sometimes those conversations come up, something breaks down, you need a prescription, but in general, those are two different paths. I'm just going to show the pictures here so that you can interact with these people throughout the day or know who they are, especially if they're not your specific provider. But we do have 4 different neuromuscular providers listed here. Dr. Matthews, Dr. Sade, Dr. Lutz, and Chandra Miller, who's our nurse practitioner. She introduced herself, but you women who are carriers might be meeting her in the clinics. We have found that primary care providers are uncomfortable or not able to set up the echocardiograms for monitoring in the community, so she's providing those services. We also have Shelley Mokler, who I haven't seen yet today, but she's the physical therapist that you typically see in clinic. Her role in clinic is to assess what your physical therapy needs are, provide instruction and guidance on stretching and exercise, She can also provide information about wheelchairs and other durable medical equipment. Typically, if you have a high-cost medical equipment that needs to be prescribed and ordered, that will be a separate appointment because the documentation for your insurance company takes quite a bit of time and effort. Katie Loebscher is one of our physical therapist you might also see in clinic, but more likely you're to see her in the research side. She does a lot of the assessments for clinical trials to monitor response to those interventions. Marcia Gilbert is the social worker, and she helps to connect people with resources, whether that be through the school or Medicaid, waivers, all kinds of different resources, and she also helps to assess coping and adjustment throughout the time. We have two dietitians, Hannah Lane and Nicole Harklew, and I couldn't find their pictures, so I put a bowl of lettuce because I feel like that's what they tell us to eat. I'm obviously one of the nurses. Lind Beamer was supposed to be here today, and I know several of you have already mentioned that you're disappointed not to meet her in person because she's behind the scenes and you don't even get to see what she looks like. So at least this is a picture of what she looks like a while ago, though. Both of us have not updated our pictures. Rachel Kinn is here today. You'll hear from her. And then Patty S.B. Pfeiffer was here earlier. She's our neuropsychologist that does the assessments for those individuals who may have learning disabilities or need further assessment for neurocognitive or behavioral concerns. The care considerations then begins to add all of these additional experts, and we do have dedicated people for cardiology, endocrinology, pulmonary, and orthopedics. And you would meet these individuals in our clinic, coordinated on a Tuesday. So each of these, it's extremely hard to read this from the side. Oh, my eyes are closer to this one. I'll try that. That each of these subspecialties continues to follow you throughout your care pathway. Things change, though, over time, so the focus of those interventions that might change as well. Specifically, one of the things that's not in the care guidelines is the connection with urology. Some of our boys in even younger years see urology for lower urinary tract problems. And then older guys see urology when they develop kidney stones, which is not well described in the literature, but it is a common thing that happens in Duchenne. These are some of our adult healthcare providers in cardiology, endocrinology, and pulmonary. So we talk about transition of care in the teen years and making sure that you are connected to someone that can care for you as an adult, because typically pediatrics was the only people taking care of Duchenne patients. So some of the other considerations that are not, of course, in the care guidelines are that our appointment scheduling is extremely complicated. Some people talk about it's like herding cats. Well, herding physicians and busy people can be equally difficult. They have other responsibilities as well. They're doing research, they're going to meetings, they have inpatient coverage. So when one of them has a conflict, your other appointments are all scheduled. We sometimes ask you to attend all of the other appointments, and we'll make that up and try to connect you with your physician at another time rather than delay all of your care. I put the scheduling number there just in case you need it, because sometimes we know your schedule also has urgent things that come up and or illnesses that you can't make your appointments. We do offer outreach clinics in Johnston, Cedar Falls, Quad Cities, and Dubuque. Again, that is to try to reduce the burden on those of you who drive long distances. We can offer telehealth visits. Sometimes those can be helpful if you have questions before your next appointment, like you were just seeing and you were thinking about new medications. Telehealth visits might be able to make a short appointment in between those bigger, longer appointments. Oh, what was my last one? Last plug. Communication with your healthcare teams, all of our teams, can most easily be done through MyChart. You can send a message through there. You can either, in your message, say, this is a message for so-and-so. Otherwise, they take a look at the nature of your message and they route it to who they think is the right person. And I can take questions now. Otherwise, we can have our whole team talk and then do questions. Does anybody have an urgent question about your care? We'll go to team member number 2, which is Dima Sade.
Also, one thing I forgot to tell you guys, if you are a family and you parked, we do have like validated vouchers, so you will not have to pay for parking. So before you leave, please come see me or Trina, and we'll give you a voucher so that you can
And then, oh, there. Forward back.
Yeah. All right. Hi. I'm Dima Sade. I know many of you. I'm going to give a general overview of Duchenne muscular dystrophy. Some of it you might know already. It might be repetitive, but it kind of set the tone for the rest of the talks. These are my disclosures. I'm a sub-I on many of Dr. Matthews' trials, but I don't receive any money for that. We are going to be aside for the REGENXBIO trial, and I do some industry advisory board work. So overview, I'm going to briefly talk about what is Duchenne, how does it present, what causes it, and how is it diagnosed. Duchenne. Oh, sorry. Is this better? Yeah. Okay. Had to adjust it for height or lack thereof. All right. Duchenne is a genetic disorder that is caused by a problem in the DMD gene, which encodes a protein called dystrophin. It results in an unstable muscle membrane that breaks down and does not heal properly. It is a rare disorder, but in the world of rare disorders, it's not that rare. It affects 1 in 5,000 live-born males, so approximately 120 males in Iowa. This is the classical old-school representation of muscle membrane and the proteins that are present at the muscle membrane and provide its stability. I don't have a pointer, should have brought one. But at the bottom, those kind of gray bead-like structure next to the red circle is the dystrophin protein. And it connects with a complex of glycoproteins at the muscle membrane, and it provides its stability when it contracts and relaxes. When the dystrophin is absent or not functioning properly, you get a disorder of dystrophin or dystrophinopathy, which includes Duchenne and Becker muscular dystrophy at opposite ends of the disease spectrum. Disruption of any of those other proteins result in different types of muscular dystrophies. And this is a slide borrowed from one of Dr. Matthews' old teaching slides, but Duchenne and Becker, the dystrophinopathies, exist along a spectrum of disease severity. At the more severe end of the spectrum is Duchenne, and then there's an intermediate phenotype, and then at the milder end is Becker muscular dystrophy, which could present with a cardiomyopathy or heart failure only. And that correlates with the amount of residual or functioning or partially functioning dystrophin that you have. The more dystrophin you have, the milder one would expect your presentation to be. How does Duchenne present? Many of you may be familiar with this or parts of this, but it most commonly presents with motor delay around 2 to 4 years of age. And then there's a period of improvement followed by a plateau. You may notice falls, difficulty standing back up from the ground, which is classically referred to as the Gowers maneuver, and it's represented on the left side of the slide. They may be calf hypertrophy. A non-insignificant number of boys with Duchenne could also have some other learning problems, speech delay, or behavior problems. Many of the kids that we see in clinic to date initially are thought to have a liver problem because for some reason they get a blood check and the so-called liver enzymes, ALT and AST, are found to be elevated, but these are also muscle enzymes, and the elevation is coming from muscle breakdown rather than a liver problem. Average age of diagnosis is around 5 years of age for now. There is ongoing recommendation to add Duchenne to the newborn screening program. I think 4 states are screening for it already, and it may come to be added to the newborn screen in other states in the relatively near future. So then people will be diagnosed much earlier. How is Duchenne diagnosed? Typically, the first lab test may be CK or creatine kinase, which is a muscle enzyme that leaks out of the muscle cell as it's breaking down. And CK is usually very elevated in Duchenne muscular dystrophy, so in the 5 to 10,000s. Genetic testing has become more the gold standard. There's many free options for genetic testing, and it can diagnose up to 95% of the boys. And then muscle biopsy is needed in some cases to help with the diagnosis. So I'm going to go back to the basics of genetics. Our bodies, everything in our body is made up of cells. And in this, every cell has a nucleus, and in the nucleus is your genetic material or genetic code that is packaged into chromosomes and contains your genes. Your genes are made up of letters, of 4 letters that make up every gene that codes for a protein that makes your building blocks. Humans have 46 chromosomes, so 22 pairs of, we call that autosomal chromosomes, plus your sex chromosomes, your X and Y. Women have 2 X chromosomes, men have an X and a Y chromosome. And the DMD gene is on the X chromosome. And so, which brings us to X-linked inheritance. About 2/3 of boys who have Duchenne have a carrier mother. And so they inherit the affected DMD gene from a carrier mother who may not know that they're a carrier. A carrier mother has a 50% chance of passing on the affected gene to every daughter, so has a 50% chance of having a carrier daughter, and then a 50% chance of having a boy affected with Duchenne. And it's relevant to know if you're a carrier in order to inform, to let you know what is your risk of passing it on to other kids, but also it is relevant to your own health. And Chandra will talk some more about it, but women who are carriers for Duchenne may need cardiac monitoring as they can develop heart disease over time. And then 1/3 of the time, boys with Duchenne do not have a carrier mother, and the change in the DMD gene may have started in them. The DMD gene itself is one of the biggest genes in the body. It has 79 exons. The exons are the coding sequences of the gene. And this is relevant once we start talking about treatment options for DMD. And this is a representation of all 79 exons of the DMD gene that have to kind of line up properly next to each other in order to make a protein. There can be many different changes in the DMD gene that affect the dystrophin protein. About 60% of boys would have a large deletion. And so they'd be missing part of the gene. So if you think of a sentence, a deletion will remove a word or several words out of the sentence. 5% have a duplication, so a repeated sequence in that gene. And then about 30% have a point mutation or a misspelling in the gene. And this is also relevant for some of the treatment approaches to Duchenne, but some of the deletions disrupt the reading frame. Remember how the exons in the DMD gene have to, or the messenger RNA have to line up properly in order to be translated into a protein. When they don't line up properly, then you don't make a protein. And so in this picture, there is deletion of exon 49 to 50. And then the edges of exon 48 and 51 do not line up properly. This is an out-of-frame mutation that doesn't result in protein production. And so when you don't have protein production, you have less dystrophin, then you're more severely affected. There is a thing called the reading frame rule, which presumes or supposes that if you preserve the reading frame and make a protein that is missing part of its building blocks but is still made, then you have a milder phenotype or Becker muscular dystrophy. Whereas if you have a mutation that disrupts the reading frame and you don't make any protein at all, then you're more severely affected and you have Duchenne muscular dystrophy. There are many exceptions to that rule, as with most rules. So then shifting to the pathology or muscle pathology of Duchenne muscular dystrophy, this is a picture of an H&E stain of a normal muscle. You see the muscle cells are sitting next to each other. They kind of have similar size range. They're organized into fascicles or bundles, and there's not a lot of spaces or fatty replacement or scar tissue in between them, as compared to advanced dystrophic muscle, where the white spots are areas that are missing muscles and have fat replacing it. A lot of the muscle cells are small and decaying, and others are regenerating and are bigger. And so there's this difference in size and overall less muscle. And this is found in muscular dystrophies, including Duchenne and other muscular dystrophies. Now, one can stain for the dystrophin protein on muscle biopsy, and this is an example. The top row is normal muscle, and the bottom row is muscle from a patient with Duchenne muscular dystrophy that is missing the dystrophin protein. The first column in that row, the green stain, binds to Duchenne and kind of binds to dystrophin and outlines that protein. And you can see in the bottom in square D, dystrophin is missing, so it's not there. This is one way to look at presence or absence of the dystrophin protein at the muscle membrane. So with that, I'd wrap up. Take any questions if you have them now, or wait until the end. Otherwise, I'll hand it over to Dr. Lutz.
Okay, I'm Dr. Lutz. I'm one of the pediatric neuromuscular doctors. I see some of you in clinic, and for some of you I might be familiar because I've been around Iowa for a long time. I trained under Dr. Matthews multiple years now, so even 12 years ago I first did some research with her in muscular dystrophy, and that's why I went into neuromuscular medicine just a few years later. So I'm going to try holding it to see if that'll help. So here's just my disclosure. So I participate in some of the clinical trials, but don't have any financial support from that. So Dr. Sade just talked to us about Duchenne muscular dystrophy and how that causes the symptoms that we see in our boys. And so I'm going to talk about some of the medications that we use currently and how that is addressing those issues. So I'm going to talk about 4 main categories of treatments that we have currently. So first, decreasing inflammation of the muscle, then trying to decrease fibrosis, then looking at the genetic therapies that we have, so the exon skipping therapies, and gene replacement. So first, looking at decreasing inflammation. So that's the group of medications, those steroid medications that we all talked to you about. So steroids, we have 3 different options now. So the prednisone, deflazacort, and vamorolone. So just looking back, the first therapy that we had was they did clinical trials in 1989 showing the effect of prednisone on improving some of the outcome measures that we have for people with Duchenne muscular dystrophy. So when I'm talking about some of the medicines, I'm going to try to tell you what evidence we have from clinical trials. So just briefly, when we think about a clinical trial, we have to come up with some sort of outcome that we can measure to see if there's an effect from the medication. So, and this will be discussed a little bit later too, but some of those things are things that you guys might remember from clinic. So the time to rise from getting to the floor, time to climb 4 stairs, or walk a certain amount of distance. So those initial trials did show improvements in those abilities in boys. And since then, we have lots of data that show that prednisone daily steroid delays loss of ambulation by 2 years, delays the onset of the need for respiratory support, delays the onset of cardiomyopathy. And then there are alternative dosing regimens out there, including weekend steroids. There's one study that looked at the efficacy or the benefit of weekend steroids and showed it seemed in a 1-year study to have similar benefits to the daily steroid with some improvement, less weight gain, and not as much decreased, or kids could grow taller during that period of time, because we can see boys get not grow quite as tall on our steroid medications. So some benefit in those side effects. So deflazacort is another option for steroid medication. So we don't have studies comparing the two options for treatment, but it has shown in clinical trials to have similar benefits to prednisone. It does significantly change how tall someone will grow, potentially some less weight gain on that medication, and a higher risk of cataracts. And then vamorolone is the most recent option that we can offer. So this medication was developed to try to have some less effects on bone health as compared to our standard steroid options. So in clinical trials, it was compared to placebo and prednisone and had similar benefits to prednisone. And molecular, like in lab tests, seem to have some benefits for bone health. And then in the longer studies, so outside of the primary clinical trial, they did show that boys' growth was not as stunted on the vamorolone. So overall, this group of medications are still one of our key or foundational treatment options for Duchenne. We don't have head-to-head trials, and so the choices that you all make about which medication is the best for your family is based on personal choices and the side effects often. So next we're going to talk about decreasing fibrosis. Before clinical trials, there's always basic science research. So basic science research noted that when we have a loss of dystrophin, that we have an increase in the activity of a type of protein called histone deacetylase, or HDAC. So they looked at when we decrease the activity or inhibit this HDAC group of molecules, what the effect was, and found that it decreased fibrosis and inflammation in the muscle. And so that's what led to looking at this as a therapy for muscular dystrophy. And so this clinical trial, the primary endpoint, so what they said they wanted to show would benefit boys would be if when they climbed 4 stairs, so this was in boys that could walk, if they could show a benefit over the time in boys that were treated with the medication. And so it showed that all boys, whether they were treated with the medicine or not, were slower at the end of the study than when they started, but the progression or the slowness was less in the groups that were treated with the medicine givinostat. And that was statistically significant. so that they met their primary endpoint. And then looking at other outcome measures, they were in the same direction, so there seemed to be some benefit from givinostat, but not statistically significant. So now they've looked at, outside of that initial clinical trial, how boys have done who have been on the medication, and comparing to controls, that they did see an improvement, that boys were able to walk for longer when they'd been treated with givinostat compared to external controls. So this is now approved for boys over age 6. And it's a liquid medication, and it does have side effects, including diarrhea, low platelets, and high triglycerides that we monitor. So it is a medicine that when you're choosing this would require frequent blood monitoring while you're on the medication. Okay, so next, moving into our genetic therapies. So as Dr. Sade had talked about, the structure of the dystrophin gene has many exons. So when I think about a gene being like the instruction manual for a protein, you can think about those exons as different chapters. And so to create a functional protein, you have to have them all be able to line up and read together. When you have a missing exon, that can lead to that loss of function of the protein. And so if we can skip over the exon that has a problem, or to combine two compatible exons, we might be able to produce a smaller but still functional dystrophin protein, and that's the goal here with these therapies. So using the same example Dr. Sade had, so if somebody was missing exons 49 and 50, if we used a medicine to skip over exon 51, maybe we could join the exon 48 and 52 to make a still functional protein. So the first medication in this class that was that came out is eteplirsen, so exon 51 skipping medication. So this was actually FDA approved based on a trial of 12 boys. And it was approved because of a small increase in the amount of dystrophin expression that was noted. And the amount of protein was less than a 1% normal amount of dystrophin that was seen. So we see treated boys show less slowing of the ability to walk compared to historical controls. So it was actually FDA approved, and then they went ahead and completed a phase 3 clinical trial, and that did show that dystrophin expression went from a 0.24% of normal dystrophin expression to 0.63% in the treated people. So this was the first, but there are now 4 exon skipping therapies that are available and several more in the pipeline. And they've shown similar effects. So now we have medications to skip exon 51, 53, and 45. And that one of our jobs as physicians is to let you know if your particular mutation would be amenable to any of these therapies and what that would look like. So these are variant specific, so not everyone with Duchenne muscular dystrophy with this type of therapy treat the underlying change in dystrophin that you have. And it is a weekly IV infusion that would continue indefinitely. So for that reason, a lot of people would choose to get port placed to be able to access this therapy. Oops. Okay, and last, gene replacement. So because we have a genetic disease that is due to loss of function, there's been a lot of interest if we could just replace that, that protein by providing that gene to the cell, could we really have significant improvement in treatment of Duchenne? So just looking, stepping back, so gene therapy is now a therapy that we use for other conditions as well. So we know this type of therapy is using a virus to deliver a genetic load to specific cells of interest so that they can make a functional protein. So for this to work, we have to package the genetic information of interest in the virus, and then you have to not have any antibodies or reaction to that virus for this to work. So if you recall, Dr. Sade told us that dystrophin is one of the largest proteins, and that influences the ability to do gene therapy. So it's actually too big of a gene product for us to insert the whole dystrophin at this point with the AV vectors that we have. So currently we're looking at delivering a microdystrophin, so a smaller genetic or gene for microdystrophin that we think will be effective. So just generally, when we think about gene therapies, there's a different set of side effects that can be that we can see. So when we give a gene therapy, we can see reactions to that viral vector, that carrier virus, and because of that, so those side effects can, in the first few days, be like cold-like symptoms, like nausea, vomiting, fever. There can be cardiac effects in the first week that we watch for, and then kind of a whole body inflammation side effect called TMA, which we watch for in the first couple of weeks. Then we can see liver toxicity. So because a lot of the viruses do, even though we want them to go to the muscle, they will go to the liver as well. We see the liver enzymes increase. And then after 4 weeks, we can see sometimes immune responses to the protein that's been made by the gene. So in the case of Duchenne muscular dystrophy, to the microdystrophin, that could be possible and cause like a muscle inflammation side effect. So because of these adverse effects, when you are treated with gene therapy, you're also treated with a high dose of steroids. So that starts before you get the therapy and then continues further for several months. And there are frequent doctor visits so we can monitor for these side effects, and frequent lab draws during that time too. So currently we have one FDA-approved gene therapy for Duchenne muscular dystrophy. So this is a one-time IV dose, and once we give it, we can't take it away, and we can't also at this point redose or give it again in the future. It is variant specific in that there are some exons that if you have a deletion of exon 8 or 9, we think that you have more risk for an immune response. And so you're excluded from getting this type of therapy. And it also matters if you have antibodies to the viral vector. So because the viral vector that is related to other viruses we can be exposed to, some of us may have antibodies just from being alive in the world. And if you do have antibodies, you're not able to have this kind of a therapy. So this clinical trial, it received accelerated approval based on the presence of the microdystrophin protein being detected in muscle. But at the 1-year primary endpoint, we saw improvements in both the people that received the gene therapy and the people that received the placebo. And the difference between the groups was not statistically significant. So it didn't actually, on what we call the North Star ambulatory assessment, so it didn't actually meet the primary endpoint, but has been approved for boys. And there have been quite a few people that have gotten this therapy, so over 600 boys have been treated. And there has been one death related to the side effects of liver toxicity. That was more recent. And we still don't know exactly how the long-term effects of this medication will be. So that's the end of what I have. I think Dr. Matthews is going to look into the future now at what other therapies are being developed.
Hello. Do you need to stand up and move around for a minute, or just keep going? Okay, we're going. Okay, I have a lot of disclosures, nothing pertinent to this conversation today. So what I'm going to cover, and we're running ahead, so this is great, is a brief introduction to clinical trials, and you've sort of heard some of this already from Dr. Lutz and Dr. Sade. Take-home message from that is that the gold standard is a double-blind, placebo-controlled trial, and we'll talk a little bit more about that, but that is the gold standard. That is what most drugs have to have in order to get approval. We're going to talk a little bit about ways that we might treat Duchenne and a little bit about, very broadly, about directions for the future. And for details about trials that are in progress, you can talk to some of our pharmaceutical representatives here. So before talking about clinical trials, I wanted to emphasize the fact that in order to get to a clinical trial, there is a lot of work that has to be done up front. Most of that upfront work is not done by the pharmaceutical companies. It's done with often federal funding. So the NIH, DOD, foundation funds, those are what do the initial steps that get us to a clinical trial. So first of all, we have to identify patients. So registries and natural history studies, I think most of you are probably in a registry or have participated in a natural history study. You're known to the clinics. Those are important. Then we have to know the natural history of the disease. We have to know what happens if we don't have a treatment, what happens to kids who have this disorder. We are pretty good about that now. You need to understand the cellular and molecular basis of the disease. Dr. Sade went through some of that. You have to know all those details because you can't start to target something unless you understand what are all the steps that get you to a disease process. You have to have a consistent standard of care to minimize the variability. So Christina talked about the care considerations. Part of the reason those were developed was so that we had a stable baseline. Everybody was doing more or less the same things. There's a lot of individual variability between guys. There are different approaches, tweaks in how we do things from one clinic to another. But basically, we're doing roughly the same things so that the variation that we see between two boys isn't just because of the way that the clinic is treating that patient. We can start to attribute some of that variation to the drug. And then you have to identify the possible treatment. That's, I put it into 4 words there, 5 words there, but that is a huge amount of basic science work to try to figure out how can we start to target those pathways we've identified, what treatments might work. And then you test those possible treatments either usually starts in cells and mice, and then it moves up to dogs and then to non-human primates before it ever gets to a person. So that's a lot of steps, and that's your tax dollars at work. And your donations to foundations, which is another huge source of that early effort to try to come up with treatments. So human trials, you hear us talking about phase 3 and all that, so I'm going to go back over this. So a phase 1 trial is you've got a totally novel drug. It's never been put in a human being before. A phase 1 trial, and in some cases, is done on healthy volunteers. It's to put this novel drug into a human body and see if something bad happens. Yeah. So kudos to those who do phase 1 trials. So it's to look for toxicity. Then the phase 2, and there are tweaks and variations on all of these, but these are the general rules. So a phase 2 trial is to come up with the correct dose. Now we're usually starting to put it into people who have the disease, and you start at a very low dose, and you just give one dose at a low dose and see what happens. And then you might, if nothing bad happens, give a little bit higher dose. See what happens if nothing bad happens. So this isn't giving it every week or every day. This is just one dose to see what happens. And then that moves into, we've started to narrow down the dose. Now we're going to give it repeatedly. And at the same time, often in those phase 2 trials, there's drug companies, they're trying to figure out, is this a drug that's worth taking forward to a multi-million-dollar phase 3 trial? Do I have any hint that this might be something beneficial? So a phase 2 trial is a small number of people to establish the dose, again, look for toxicity, understand what the drug does in the human body, and decide whether or not you're going to move forward. The phase 3 trial is the one that we all know and love. That is usually, if you've got hypertension, it may be thousands of people. If you've got Duchenne, 100 or 200 people in a phase 3 trial. This is going to be placebo-controlled almost always, and I'll talk about that a little bit more. And the phase 3 trial is what they take to the FDA to say this drug worked or this drug didn't work. If it didn't work, they don't take it to the FDA. Let's see. And so the phase 3 is millions and millions of dollars. This is a big investment on the part of the drug company. It's a big investment on the part of you guys who participate in those trials. Then, if it's approved by the FDA, there typically is a phase 4 or some sort of a post-marketing surveillance to see what happens in the real world outside of the clinical trial setting. And in rare diseases, some of these phases are combined. So that's the general process of what happens for a clinical trial. I told you I was going to talk a little bit more about placebo-controlled trials, because people sometimes say, well, we've got all this natural history study, all this natural history data. Why do you have to have a placebo arm? Why do I have to be in this trial, go through all these things, and maybe not get the drug? So some of that natural history study isn't contemporary with what we're doing right now. So you have to be able to compare people being treated the way we're treating people in 2025 and have a level playing field between the placebo group and the treatment group. You have to be able to compare. I think Dr. Lutz mentioned that the people in the Elevidys trial, the people in the placebo group did a little better than they expected, so they weren't able to show a difference between the treatment and the Elevidys group in the endpoint that they choose, although they showed a difference in other endpoints. But you need to be able to compare, did my treatment do better than people who weren't treated over the course of that trial? There could be other things that are going on. You could have had some other change in practice, or people benefit from the increased attention. You're seeing the clinical research staff every week or every month, and sometimes people get better just from that constant contact and reviewing everything every day. So you have to have a placebo group. The placebo arm is often followed by what's called an open label extension. So we know that it takes a major commitment on your part to enroll in a trial, and some of you have done amazing things by enrolling in trials. In order to sort of offer something potentially beneficial before we know whether the drug worked. At the end of the, say, 1 year period that you might be in a placebo, everybody in the trial, you still don't know what you were taking during that year, but everybody is now offered the active drug until we know the results and whether, and it goes to FDA or is determined to not be effective. If it's determined not to be effective, then everybody stops the drug. If it's determined to be effective, then you keep taking the drug because you participated in the trial until the FDA approves it and you get paid. I mean, until you can get it commercially, sorry, if it's FDA approved. Okay. Hopefully that all made sense. So the average time for drug development, and this is an older slide, but I don't think it's gotten a lot quicker, is about 12 years. So everybody feels like everything takes too long. It takes a long time to get a drug approved by the FDA. And the success rate, so drugs going into, again, this is 2019 data, but drugs going into a phase 1 trial, about 10% go to FDA approval and are something that you can buy. And for those who go to the phase 3, that placebo-controlled double-blind study, about 50% get FDA approval. The numbers have been going up a little bit, but say roughly 50% of phase 3 drugs will get FDA approval. And if they don't get FDA approval, it's because they didn't work or there was excessive toxicity. And we've seen both of those possibilities in the Duchenne drug pipeline historically. You've already heard from Dr. Lutz about the drugs that we currently have available to us. So you can see that over the last 10 years, Duchenne has done, it's been amazing, amazing. I've been doing this a really long time. Christina mentioned that. Both of us have been doing this a long time, and it is amazing that we now have 8 drugs approved for treating Duchenne muscular dystrophy. So that is real progress when you think about the timeline to get to here. Just to remind you, we're talking today about drugs, but to remind you that not everything that improves outcomes in Duchenne muscular dystrophy is a Duchenne-related drug. So for example, new cardiac medicines, heart failure medicines are effective whether you had a myocardial infarction or you have Duchenne muscular dystrophy. Some of those are really important. I showed up here that early treatment before you have documented heart disease prolongs survival. So just routine heart medicine prolongs survival for guys with Duchenne. Non-invasive ventilation and the cough assist, those have made a real enormous difference. So we've made a huge amount of progress over the last 10 years. Some of it is those 8 approved drugs that we have. Some of it is progress that has been made in other fields. So, you know, we have a lot to be optimistic about and be happy about. Okay, now we're going to move on to thinking more broadly again about how you might treat Duchenne. And Dr. Lutz gave a similar list here. So we can reduce muscle inflammation, we can stabilize the muscle cell membrane, we can replace that dystrophin gene, we can repair the genetic variant, the genetic mutation that causes the disease. We can modulate the pathways downstream from that deficiency of Duchenne. So if you're lacking Duchenne, there is then a cascade of events that results in muscle cell damage. We can modulate steps along that cascade. And then we can improve the overall health and ability of the muscle to repair itself. When we think about all of those options and we think about what might a potential a new treatment do. So if you look at the top of that graph is stronger, the bottom is weaker, and across the bottom is time or age. So if you start strong, if we don't do anything, we know in Duchenne you get weaker over time, and that's the bluish line at the bottom called natural history. If we start a treatment, you can slow the progression. That's what a lot of our therapies do. They slow the progression. That's good. We want therapies that slow the progression. That gives us time to come up with new therapies. It gives us time to, that's the main thing, it gives us time to come up with new therapies. You can stabilize the disease entirely. So everybody that I know with neuromuscular disease would be thrilled if I could guarantee that you take this medicine and you're going to stop right where you are. Because most people have sort of adapted to where they are. If we could stop things right where they are, that permanently, that would be great. And then you can actually cause improvement. That's the, that's the golden ring. That's the thing we're all hoping for. You can cause improvement. This is what I can do with PowerPoint. Those graphs are actually more complicated. You can have improvement followed by decline, stabilization followed by decline. But you get the idea. There are a lot of different possible positive outcomes from a new potential therapy. So April 18th, I looked at clinicaltrials.gov, and I looked at Duchenne, either not yet recruiting, but registered or actively recruiting, male only, and studies that were interventional, so treatment studies. There were 44 studies listed overall. When I limited that to studies in the United States, it came down to 14. 6 are related to gene therapy, 3 are exon skipping, 1 was a cell-based therapy, and 4 are other unique mechanisms. And that doesn't include the studies that are close to enrollment but are still collecting data. So that's quite a lot in the pipeline. So on the horizon related to gene therapy, the goal here is to try to increase the therapeutic benefit and decrease the side effects. And Dr. Lutz went over those, the information about side effects. So ways you might do that, you can expand the current therapy either with repeat dosing. So she mentioned that you can only give these viruses once right now. So there are studies to try to figure out how can we give that virus again, or how can we give it to people who have pre-existing antibodies to that virus. You can look at new ways to deliver the gene. So we're currently using a virus. Might we use a nanoparticle or a lipid particle, or is there another way to deliver the gene? Can we come up with viruses that don't go to the liver so much so you don't have liver disease? Can we come up with viruses that really just go to the muscle or the heart? And all of those things are in progress. You can come up with delivery approaches to decrease the total amount of virus you have to give. We know that some of the toxicity is related to the amount of virus you have to give. So can we give gene therapy in the spinal cord, for example, to try to decrease the total number of viral particles we have to give? And then the last thing is, Dr. Lutz mentioned to you that right now that virus can only hold a teeny tiny version of dystrophin. Dr. Sade mentioned dystrophin is massive. We have to cut out most of it to get it to fit into a virus. So there are companies that are working on how do we come up with a way to put the entire dystrophin gene back into the human body. Exon skipping, Dr. Lutz talked about exon skipping. Right now, the exon skipping treatments require weekly IV infusions, and the amount of dystrophin made is not massive. She told you 0.63% of normal. That's not a lot. So the goals of exon skipping are to increase the therapeutic benefits, so increase the amount of dystrophin that you get for exon skipping therapy without increasing toxicity, and ideally decrease the frequency so you don't have to get an IV infusion every week. And there are new drugs that are in development to try to get the exon skipping drug into the cell more efficiently, increasing the dystrophin production. And there's also a lot of interest in trying to come up with exon skipping drugs for other exons, or even to potentially combine exons, so that right now we have a small portion of guys with Duchenne who are amenable to exon skipping therapies. We might be able to increase that number through novel ways through new drugs and through ways of combining them. And then the other mutation-specific approach that has been, I think there are people here who have been on this experimental trial for 16 years, something like that. Anyway, long, long time. So this is, if you have a specific mutation that results in a premature stop, so the body is going along and reading the gene, it hits a stop sign, and you then don't make the rest of that dystrophin molecule. If you can tell the body, just ignore that stop sign and just keep going, keep reading, that would allow you to make an almost full-length dystrophin molecule if you have that kind of specific mutation. So there is a drug that has been in trials to promote that read through the stop sign. Other add-on therapies, there's a cell-based therapy that is currently in clinical trial, and that we expect to get an FDA decision about sometime this year. It's designed to basically make the environment in the body healthier for cells. It should improve the environment for the cells in the heart and in skeletal muscle. So we'll find out whether what the FDA thinks of that data sometime later this year. And then Edgewise Therapeutics is here, and apologies for the simplification of the approach here. Where's John? There you are. But it basically tries to decrease the amount of muscle injury by changing the proportion of the different white meat versus dark meat in your muscle. Just like chickens, we have white meat and dark meat. It changes the distribution of white meat and dark meat in your muscles to decrease the amount of injury that your muscle sustains. So, challenges for the next 10 years. We have 8 treatments that are approved, and we have a lot more in the pipeline, and more are expected. So we're going to have a lot of treatments. So we are going to need to try to figure out when should each of those treatments be started, and in what order. We can't just start everybody on everything all at once, but what is the right timing of each of those treatments? How do we minimize any side effects? Which treatments are most effective when used together? And are there patient characteristics, aside from just do you have a mutation that we can use this drug in? Are there patient characteristics that allow us to choose the best drug for you? We don't know that yet. Another question, how are we going to pay for this? As you know, Elevidys is about $3.2 million for one IV infusion. Each of these drugs is very expensive. I told you it costs millions and millions of dollars for the pharmaceutical company to carry out a phase 3 trial. They also have to recoup the investments of their investors. So it's an expensive process. And how are we going to pay for this as a society? We're thrilled at all these new drugs. We're thrilled at the treatments and the improvements that we've got. How is across neuromuscular diseases, how are we going to, as a society, pay for it as we get more and more and more, and they all cost large amounts? And then, closely related, and I'm looking here at Christina, and Rachel, what army is going to navigate the prior authorizations and all of that? And you guys know this. You already have enough on your plates. You can't do it. We can't do it all. There has to be, there's a breaking point at some point, or we're going to have more people or something like that. We have a lot of challenges. However, We're excited about the future. I'd remind you that some, but not all of these evolving treatments are going to work. Some treatments might work for some people and not as well for others. We know that the clinical trials take time and commitment and energy and braveness on all of your parts, and we thank you for that. We also know that trials have risks. And there's been amazing progress in the last 10 years, and I expect that to continue and accelerate. So we're in a really good place. So thank you. I think I probably went over my 15 minutes, but thank you for your attention. We're still early? Perfect.
All right, everybody, we're gonna go ahead and get started. So if you guys wanna take a seat, that would be wonderful. So I am going to welcome up Rachel Kinn to talk about access to pharmaceutical therapies. Green is forward. If you need to go back, red is back.
Oh, perfect. This is.
And you don't have to like point it at. You
Okay.
can just click it. It doesn't matter. Apparently, it'll get it everywhere.
Sounds good. Okay. Okay, everyone. I'll go ahead and get started here. If you guys are just settling down, don't worry, take a few minutes. So we've heard a lot about the clinical aspects of medications, including trials and then our commercial drugs that are approved, but I'm focusing mostly on access. And going through pharmacy school, I never thought that this would be part of my job. I focused on the studies and how medications work in the body and how they're used, but truly medications don't work if people cannot get them. And so this has become an important part of my job. I know it's important to all of you guys as well. So I do have a few conflicts of interest. I sit on the Iowa Medicaid P&T committee. I also am a clinical consultant for a small group. And then I'll mention some off-label use of medications, but that won't be the primary aspect of this talk. And so the two different things that dictate access to medications are insurance. And so in the US, insurance, unfortunately, rules everything around us. And then just working with your pharmacy is the other thing that I'll give some tips on in a little bit. So make sure we're all on the same page and we understand some of the terms that I'm going to talk about and the terms that I talk about during our appointments. I'm going to pull this out real quick. Okay. And so I'm another member of the team that hangs out in the background a lot. So unless you guys have a certain question about medications or access to medications, you may not have met me, but I know I'm starting to meet a lot of you guys as you're getting started on these new therapeutics. But if you ever have any questions, please always ask your neuromuscular team, and I'm happy to come in and chat with you guys. Okay, so insurance is basically just the system that helps defer costs and spread costs across all of the members of a plan. And so in the United States, we kind of have two main categories. We have commercial payers that are our big names, Wellmark, Aetna, et cetera. In the state of Iowa, we have Wellmark as our big commercial payer. But then we also have some public funding that for most of our Duchenne-aged patients, that's Medicaid. And so patients can have just commercial insurance, just public insurance, or a combination of these two. And so a lot of patients with Duchenne do have the combination. And so if they do have a commercial payer, then they do have a secondary insurance that is the private Medicaid, the public Medicaid or an MCO. And so where a lot of patients run into problems is when primary insurance and secondary insurance aren't talking, or they have different medications that are covered, and that can be a challenge that I can help you work through. And one caveat is that although a patient may fall into a certain category, like they may have a Wellmark plan, every single insurance is different. And so when you show me your card or you tell me your specific plan name, that doesn't necessarily mean I know exactly what is going to be covered under your insurance plan or how much your cost sharing will be. One thing I commonly discuss with patients is formulary. So formulary is a set of medications that an insurance decides if they're going to cover or not. Just because it is listed on a formulary, it's listed as covered, doesn't necessarily mean that it will automatically get covered right away. Oftentimes there are certain criteria that their insurance wants you to meet. And it's super important to note that that doesn't necessarily dictate, or that doesn't always fall in line what we as your clinical team feel like is the best option for you. Insurances tend to be more restrictive than what we would like to use medications, than how we would like to use medications. And so that's where myself, Christina, all the members of our team work together with insurance to help get these medications to you. And then I had mentioned before that just because a medication is covered doesn't necessarily mean that it will be free. And so insurances often have cost sharing, they have some sort of cost sharing. And so that could be a copay or a coinsurance. And again, every single plan is different. These copays and coinsurances are different than your premiums. So the premiums, if you have commercial insurance, are the things that you pay at the beginning of the month that just kind of like get you the card. And then once you actually have a service or receive a medication, then you have to usually pay additional costs. Copays are typically tiered. They're like flat amounts. So if you get charged $50 or $100. And so the insurance determines what tier a medication falls into, not us as your clinical team. Co-insurance is usually you pay a cost of that a percentage of that cost or the charge. And so this is when you go to the pharmacy, you may end up with a funny number that you have to pay, like $43.16. That means that you are paying a percentage of the cost that the pharmacy buys the medication at, and again, determined by insurance. Where you guys see me a lot, or where I talk to you, is when we get into the logistics of actually working with insurance. So those PAs, or prior authorization, are those criteria that insurance put in place that dictate when they will cover the medication or not. Again, not dictated by your clinical team, that's just insurance. Frequently, insurance will limit the specific criteria or access to the medication based on the clinical trials. And so sometimes as your clinical team, we can predict if a medication will be covered by insurance if you fall in line with what was studied in the clinical trial. We know that medications are effective for patients who are outside of those clinical trial ranges. Clinical trials are designed to hopefully show efficacy for the medication in this kind of like perfect population. So they tend to be patients who are earlier on in their disease, but patients can still benefit from these medications if they're later on in their disease, and that's when we recommend it. Or that's when we can recommend therapy. Or when I say we, I mean your neuromuscular providers can prescribe them. But we can still help you access them. And so if your insurance says, no, we're not going to cover this medication after we submit that prior authorization, then we can go on to the appeal process. And so appeal means that myself, Christina, Linda, and your providers all team up and we write a letter to insurance explaining why we think that you or your child can benefit from the medication. Sometimes insurance will allow this and they will cover the medications, sometimes not. This is altogether a long process. And so to put this in graphical form, if we're starting over the left, that's when your medication is actually prescribed. An electronic prescription is sent to your pharmacy. Then the pharmacy reviews it. It goes back to our team saying, insurance is not paying for this medication. Please tell insurance why you want this. We submit the paperwork to insurance. Insurance takes their own sweet time to review it. And when I say own sweet time, the initial prior authorization review can take anywhere from 1 week to 10 business days. A lot of times I see closer to 3 to 5 business days. And then if it's denied, we then need to appeal it. So then it comes back to us. Our clinical team writes a letter. We submit it to insurance, and then they take their own time to review it. Frequently, insurances say that they can take up to a month to review it. Some are a little bit longer. I would say most insurances take a month. And so when we are discussing these new medications in clinic with you, I try and provide the caveat that, we're discussing this now. We may be doing our baseline lab work now or our baseline evaluations, but it's highly likely that your child will not be starting on this medication for a minimum of a week, if not a month, 2 months, or 3 months if we end up getting authorization. So we ask that you be patient with us. One of the other challenges and questions I get frequently is, how do I afford these medications? Dr. Matthews explained that the cost that goes into these medications is really great, and that can be sometimes reflected in the cost. And so staple medication like steroids, prednisolone have been around for many, many years, and they're generically available and super cheap. So a lot of the times I don't usually get questions about that. But if you're getting approved, or if your child is getting started on one of these name brand medications, they can come with significant costs. And so, like I said, you have insurance. You still are responsible for cost sharing. And so that's where kind of I come in. I will help you guys partner with the manufacturers. A lot of times they have copay cards or assistance programs that are available. There are grants out there available. And so there's some individual disease specific grants that are available, but then there's also some universal just medication access grants. If you ever have any questions or need assistance, please feel free to reach out. At the university, we also have our Medication Assistance Center, which I partner with, that helps us to access medications and work with these manufacturer programs. Sometimes insurance will never cover the medication, and that's when we can go back to our manufacturer partners to see if they would be willing to supply the medication to you guys free of charge after an application process. Some other questions and concerns I frequently get are just kind of logistics of working with your pharmacy and prescriptions. So when medication, if we have just a normal prescription non-specialty medication, for our Duchenne boys, it's commonly our heart medications, so our lisinopril, our carvedilol, or just our prednisone. These medications can be obtained from pretty much any single pharmacy. And so when you get a new prescription, it's always assigned a new prescription number. And so if you are going to fill a medication, you may have to call into a pharmacy to request a fill of medications. If you are receiving a renewal of a prescription, and you have utilized the electronic resources in the past, meaning the automatic refill, you may have to also call into the pharmacy. So this is a common problem that I see patients have, is when they're coming to see us for their 2-year follow-up after starting prednisone or prednisolone, so to say, then you'll have to call into the pharmacy because we sent in a new prescription for that. And I guess I got a little bit ahead of myself. But legally, in order for a patient to receive a medication, to receive a prescription from their provider, they must have an established relationship with them. And so that meaning that your provider needs to be seeing you and evaluating you. And so that is dictated by your prescriber. However, we usually ask to be seeing you every 6 months, every 6 months, every 1 year. Sometimes it can get elongated, but it's determined based on your provider. But they need to be able to see you to make sure that you are responding to the medication appropriately and not experiencing any side effects. And so that's part of why it's so important to come for ongoing appointments with our team. The state of Iowa requires prescriptions to be sent electronically, and so sometimes previously patients would call our clinic and they would ask for us to call something in if they ran out of refills. Legally, we actually can't do that anymore. It must be sent through the computer, so it can be there's a few extra steps on our side in order to get you guys medications. Generic medications. So in Duchenne, pretty much our primary generic medications are prednisone, prednisolone, our cardiac medications. Recently, deflazacort went generic, and generics do offer a safe and effective alternative that can potentially save you guys money. And so generic medications have been approved by the FDA and are shown to be therapeutically equivalent to their brand name counterparts. And so if your child is on brand name Emflaza and you have any questions about switching over to deflazacort, I'm happy to talk to you. Many of our other medications, given that they're brand new, are still brand name, but as we look 5-10 years down the road, they will eventually become generic. Medication access concerns. And so sometimes, so a lot of our new medications are what are deemed to be limited distribution, meaning they're only available through a certain set of pharmacy, a certain set or certain pharmacy within the United States. And so for our medications, that is dictated by the manufacturer. And so when these medications that are limited distribution become available, there can sometimes be some access problems. The pharmacy may not be contracted with insurance or unable to bill. And so I'm happy to work with you and work with the manufacturers to help expedite access to these medications, but it can sometimes be a little bit slow in getting patients started. Now that we have several what we call small molecules or oral medications that are available, you may also have to be working with several different pharmacies. And your exon skipping medication may be coming from one pharmacy, your steroid may be coming from another pharmacy, and your givinostat may be coming from another pharmacy. So it can sometimes be a lot to coordinate. And so when you're talking with your pharmacy team, and then those manufacturer patient access team, let them know what you need and what you want. Sometimes that is a decrease in calls. And so I know with these specialty medications, you have your pharmacist team, and then you have your pharmacist team coming where your medication is being dispensed from. You have your manufacturer team, and they be calling you, and then you have that ×2 or ×3. That's a lot of calls each month as a caregiver. And so feel free to ask them ask them for what you need and what you want. So that's my tip to help kind of make your lives a little bit easier. Luckily, we haven't been super impacted by drug shortages within the Duchenne and Neuromuscular community. However, this is a possibility, especially moving forward with tariffs. A lot of medications are manufactured outside of the United States, and so we anticipate this becoming a bigger problem moving forward. So if you or your pharmacy is ever having problems getting your medication in, please call our team and we will help to troubleshoot with you as much as possible. And then just Iowa Medicaid. Sorry, this is kind of jumps around a little bit. But just some kind of 101s of working with Iowa Medicaid, either as a primary or a secondary insurer. And when I say Iowa Medicaid, I mean our fee-for-service, meaning true Iowa Medicaid, but also our MCOs, so our WellPoints and our Iowa Total Cares, et cetera. So in order to qualify for Iowa Medicaid, you must reside in the state of Iowa. I'm talking about Iowa Medicaid because that's where we are and that's where we live, but I understand that some of our patients are coming from out of state as well. If you have additional questions about your state, feel free to reach out and I'll try and help triage as much as possible. Some things that can be a source of frustration for patients with Medicaid is that Medicaid limits patients to receive only 30 days of medication at a time. And so you cannot get those 3-month fills. So this does require you to receive the frequent shipments of medications from a specialty pharmacy or to go visit your in-town pharmacy quite frequently as well. The biggest thing that I see patients run into, or biggest problem, is this 90% rule. So Iowa Medicaid will only let you refill a medication once 90% of the medication you have at home is complete. And so when you're receiving 30 days of medication, that is day 28 of the month. And so you kind of gotta be really, really on top of your refills in order to not run out of medication. This can result in some additional challenges when your medication is being shipped from out of state from a specialty pharmacy. And so if it is day 28 and you're just getting a refill, then might arrive on day 29 or day 30, and then you're set to run out of the medication. We know in the Midwest, our weather can be really inclement, and so I've had patients who their FedEx shipment has been delayed because there's a snowstorm and the FedEx workers can't safely get to their home. So depending on the medication, we never want patients to miss medications. However, some medications are more dangerous to miss than others. So if you anticipate that your medication may be delayed, you may miss doses, and I say you, I meant your child may miss doses, please reach out to our office and we can help walk you through if there's an alternative option or kind of how to handle this and in the meantime. And then another question I get, especially when working with the specialty pharmacies, is problems with billing insurances. And so for Iowa Medicaid, if it is a secondary payer, meaning that you have a commercial insurance like Wellmark, Cigna, Blue Cross First, and then you have a secondary Medicaid, the secondary Medicaid in the state of Iowa does not require a separate PA. And so you may be getting a message from the pharmacy that says, hey, talk to your doctor's office because they need to do additional paperwork. There's just certain electronic claims that need to be billed on their side. And so if you're getting these error messages or the pharmacy's telling you about these error messages and that insurance isn't covering your medicine, it's not being billed, it's not going through, and this is unexpected, meaning that you haven't heard from our office that something has been denied, please call us. So that's the general takeaway of this is that myself and my team are here, and all of our team are here to help you guys access medications, so just reach out to us. So that's the end of my chat. I know that went a little bit too long, but questions? Okay, thanks. Oh, yeah. Excellent question. So that is very patient dependent. So sorry. The question was, should you pursue a secondary insurance if you're having problems, or should everybody pursue it? So if it's a secondary Medicaid, there are certain provisions that need to be met, either disability status or family income, or there's some additional ones that would qualify a patient for Medicaid. But I would say don't wait. And so if you believe you or your child may qualify, please talk to us in clinic. So Christina and I, our social worker, can talk to you about if your child may qualify. But if you think you may qualify, I don't recommend waiting until you have a problem, because then it takes a while to get enrolled. Oh, okay. The question was, are we seeing improvement in getting patients access? I would say, I don't know about the details specifically. Christina, have you seen improvements with the recategorization?
Here. I could probably talk loud too. Our social worker has been talking with families about there is a priority needs assessment that is available, where if you've already been waiting for a long time, that avenue might be able to bring you closer to the top of the list for your application. Certainly within your family, if your income changes, if your insurance status changes in other ways, it's always appropriate to reapply to Medicaid to get that secondary. And then the other is that if you've been denied Medicaid because you did not meet disability requirements once, it's appropriate to appeal that decision. Sometimes you might need to reach out to us to have a letter supporting your disability claim. The other piece to that is that if you've had a change in mobility and things are getting tougher for you, you might then meet the criteria to get Medicaid as a secondary payer. And then some of you I know have two private insurances as well. Like if you have insurance through mom and dad, that's almost never a bad thing.
Any other questions? Good questions.
While transit's coming up, I'll just add.
So when you have two primaries or two commercials, it can be helpful, but it can also be a convoluted process if they are both primary versus a primary and a secondary, because they are billed differently. And so it ends up being it depends on the plan. So sometimes your premiums are so great that you don't end up saving money if you have two commercial insurances. And so it totally depends on the plan that is offered. And so when patients are looking at insurance, what I generally recommend is that you look at your expected cost. When you try and forecast your expected cost, look at not only your premium, but your out-of-pocket maximum and your deductibles. And so add all of those up, and basically with a child with special needs, expect to pay that every single year. And so that's how I recommend comparing plans when you're choosing one, and then see if you can get two commercials versus two primaries versus a primary and a secondary. So a primary and a secondary means we can bill them sequentially. So any cost that is not picked up by the primary can go to the secondary, and you can even have a tertiary, whereas two primaries, you bill one or the other. And so it doesn't always equate to cost savings. Okay, I'll let Chandra go. Thank you all.
A little bit of a softer talk. So I'm Chandra, I'm the nurse practitioner with the group. I've been longer involved with clinical trials with Dr. Matthews' group, more recently in the last couple of years as a nurse practitioner. So this is taking care of women too, because as we've seen, the boys with Duchenne, it's very complex and there's a lot of things, and we want to make sure that we pull the women out too and that they are getting the things they need as carriers. So our carrier clinic is really just folded into our neuromuscular clinic. It's not separate in that sense, but the things that we offer as a part of it is that you've got a dedicated team of experts. We've got our neuromuscular physicians who've been seeing carriers for a very long time, myself more recently in the last few years, and then Christina Trout is our nurse specialist who does the genetic counseling for the clinic. And we, of course, have other providers like physical therapy. I think it's a family-based model of care. A lot of times the appointments are combined with the boys' appointments, and really it's a part of their comprehensive health care that we're just seeing everybody, because the genetic counseling is one and the same. So we coordinate those, and it's comprehensive in that it really does consider the entire you. I think everybody has a unique journey as to how they found out that they were a carrier and how they came to our clinic and what that means for them and their personal decision-making and their health choices. We're very flexible. We offer it at multiple locations. So I see patients at Johnston Outreach Clinic. I see them at the Peds Specialty Clinic. We often add appointments on quickly, or we've just combined it when you've got your son coming in. So in terms of where we see you and when we see you, that's pretty flexible. And then the echocardiograms, that's something that we've really tried to help facilitate, whether it's at the university when you're coming for another appointment or to help you figure out where you can have this done locally. And sometimes primary care providers will order those, or sometimes I'll provide the order, even if you're not having it done at the university. And then to facilitate referrals to other specialists that you might need to see. So this would be cardiology, or for family planning, that may include advanced reproductive services. So in the very simple and general sense of what is a carrier, that's typically talked about in the setting of an autosomal recessive disorder, and I won't get much into genetics because that's been covered well today. But when we think of autosomal recessive, that has to be inherited by both parents for the child to have disease. But as we know, Duchenne is unique because it's on the X chromosome, and boys are affected because they've got one of those with that change, and that's how they get affected. And women have two, and so they would be a carrier with one of those X chromosomes having the change gene. And these can be inherited or they can be spontaneous. Most are inherited, but then about a third are spontaneous or de novo. We get carriers into our clinic in a lot of different ways. The top two are probably the most common pathways to our service, but the bottom two apply as well. So family pedigrees. When we see a boy with Duchenne, a part of what we all do, and especially what Christina does, is we review those pedigrees as a part of their comprehensive care plan. And that helps us to identify female relatives that might be at risk. And then based on pattern of inheritance and family history, we can also identify obligate carriers. And that term just means that we know you're a carrier based on those things. We don't need to do the testing to confirm that you are a carrier. We've also recently gotten a lot more referrals from OB-GYN. There's been different places that OB-GYN has sent patients, so sometimes they send them to cardiology genetic counseling, and that person will do the genetic counseling and they'll order the echocardiogram, but then it's not always clear where the patient goes from there, who's really following them. So we've been getting more of these recently, and we try to make sure we're the initial visit for the patient, and then we also can follow them a little bit more. And then if they have other manifesting symptoms like muscle symptoms, we can help navigate those too. Some younger girls or some women may have had incidentally found elevated liver enzymes and a CK through workup for other things. And I've got another slide on that later. And then if some women have had cardiac symptoms or cardiac evaluations, often not even at our hospital, maybe at a place like Mayo, and as a part of that evaluation, they have been found to be a carrier of Duchenne. So a lot of different ways that a woman could get to our clinic that we are seeing them. So in terms of counseling and testing, these are kind of the broad categories that we think about. So of course the mothers of children with Duchenne or with Becker, and then any at-risk women that we identify in the family history could benefit. And then that category, that the last one I had on the previous slide, that women who've come in because of unexpected muscle weakness or cardiac symptoms, and then we're found to be a carrier, and then we're kind of doing the counseling on the back end for them. I did put in a special consideration for our young female relatives. So typically the earliest age we would see them is in their teenage years. We don't want to test or counsel before then because they should have some understanding of biology and reproduction. And then importantly, they need to be an active participant in the decision making. So I would say more often they're coming in end of high school, early college years is more common. And then the carrier testing that we usually do is free or sponsored testing. A lot of times it's a blood drawing clinic that we're doing, or we can send home a saliva kit. So when you get carrier results, if it's positive or you are identified as a carrier of Duchenne, as we know, then that's a 50% chance of passing that on. If you pass it on to a girl, she would be a carrier. If you pass it on to a boy, he would be affected. And then one thing we talk a lot about with our patients is that a normal or a negative test result does not mean zero risk, and there's reasons for that. So we can't completely eliminate the risk even if you are not identified as a carrier by blood, and that's because of those de novo or spontaneous mutations that can occur, and then germline mosaicism, and that is where the variant is confined to the ovaries, and it's not something we would identify in the blood. And then of course there's always variants of unknown significance. These are not things that are currently thought to be disease causing, but that can change over time, but currently they're a VUS. So some special considerations if you're identified as a carrier from something like prenatal screening and you are currently pregnant. OB-GYN, we just like to clarify the counseling that we do versus what OB-GYN will do. So OB-GYN is going to be more comprehensive prenatal counseling, and they're going to discuss other autosomal recessive conditions that you might want to be tested for. So we still encourage you to have that counseling. Additional testing during pregnancy, there is the cell-free DNA that can help predict the sex of the baby. So if it's predicted as male, some women do choose to go on and do additional prenatal diagnostic testing. Typically that's an amniocentesis. There's a certain point in pregnancy where that can be done. I think it's after 16 weeks, but I'm not exactly sure on that. And then of course there's risks with that because it's transabdominal. So it's something to talk to the advanced reproductive people about. And then in the neuromuscular side of things, Our counseling is really specific to that inheritance of Duchenne or Becker. And we're going to talk about things like the specific gene mutation and what the predicted phenotype might be. If there's family members that are affected, keeping in mind intrafamilial variability, we might say that that could help predict a clinical picture, or we might say, what's in the literature based on what we know about the mutation. And then finally, it's joint decision making. So women, let's say there's a woman who is a carrier, the sex of the baby is predicted as male, and we know we're going to do confirmatory testing after the baby is born. Usually we don't do it earlier than 6 weeks. There's not typically a need to do it sooner than that, but that's a joint decision making that we go through in the clinic of when to bring them back after delivery. So health risks associated with being a carrier. This is something that is unique with Duchenne. When we're talking about like the autosomal recessive conditions and you're a carrier, you don't typically have symptoms with most conditions, but this is unique with being a carrier of Duchenne. There is cardiac risk, and it's that you could develop dilated cardiomyopathy. There's a little bit of variability in the percentages reported, but typically I say around 10%. There's skeletal muscle symptoms. Less common would be weakness, but more commonly would be cramping, myalgias or pain, and women report fatigue. We have seen learning difficulty in some of our younger girls that are carriers. Because the liver enzymes come from muscle too, you can have elevated liver enzymes. And that's important to know if you ever have labs drawn through a primary care for other evaluation, routine screening. If you have those elevated liver enzymes, we usually recommend checking a CK so that we can help to identify, is this coming from muscle because we know you're a carrier, or do you have something that's isolated to the liver that needs a proper evaluation with your PCP? And then of course the risk to offspring. So some carriers might be interested in more advanced family planning options like IVF. And terms to be familiar with would be they can do pre-implantation genetic diagnostics, and then things like donor eggs or embryos. So currently for cardiac monitoring guidelines, if you have normal echocardiograms, then we typically say every 3 to 5 years. If a woman has maybe more cardiac risk because of other things like hypertension, I might do it on the shorter interval of 3 years, but every 3 to 5. Usually starting that around college age is a good time, and then typically you'll get an EKG to look at the rhythm of the heart, as well as an echocardiogram, which looks at heart function. And then we also are sometimes using cardiac MRIs, which can help with earlier detection of fibrosis, which is scarring within the heart muscle. Mostly that's done through cardiology, so if I refer a patient on, they will probably get a baseline cardiac MRI. And then special considerations during pregnancy, because we know heart function can change during pregnancy just by the natural increase in the workload on the heart. If there's a question on the echo, if we do it during pregnancy, sometimes I will recommend getting another one sooner and after delivery, just to evaluate if there's really any true risk there. And other management considerations. So if there is abnormal cardiac testing, we do have the cardiovascular genetics clinic at the university, or women will opt to see cardiology locally. Either's fine. And that's because there's medications and treatment available for cardiomyopathy. And muscle symptoms, it's very comprehensive, it's very patient specific, and it depends on if we're talking about weakness versus pain versus fatigue. But that's a really comprehensive approach that we offer and walk every patient through. Mental and emotional well-being, I think, is a big component of being a carrier of Duchenne. A lot of the advocacy groups, which I have on the last side, offer the peer support groups, and Jet Foundation talked about it in the beginning this morning. But counseling and being involved in those can be very helpful. And then if we have someone with learning difficulties and they're in school and they might need an IEP, we can refer to neurocognitive testing for those girls. And then comprehensive evaluations, whether it's within our clinic or with another service. If there are symptoms that a woman has that's kind of outside of what we would typically expect with being a carrier, like if I see you, I may recommend then an exam and a different appointment with the physician. or with another service to see if there's other underlying conditions that you have to better explain the symptoms. So resources available, Jet Foundation that sponsored the conference today, and then I've listed the other ones there. There are registries that women can sign up for and participate in. They typically post research and publications that are available on what we know about carriers. There's education like monthly webinars that you can sign up for and different community groups where you can be a part of the conversation. And they've got some very nice brochures and handouts. And then there is advocacy efforts for things like access to care and insurance coverage. And that comes into play, you know, for echocardiograms, for example. We want to make sure that those are being covered because it is a clear risk of heart disease, of the cardiomyopathy. So we don't want there to be an insurance problem when you're getting your recommended echocardiograms. And I can take any questions now. Otherwise, if there's anything you want to ask me, just pull me aside and I can do those later.
Then real quick, I just want to say, so as she mentioned, there are a ton of resources out there. Trina, myself, along with some others in the community, did create a, 2 pages. It's like Journey to Diagnosis for carriers. So what they have found is, since there's no current standard of care for carriers, what they have been told in their settings in terms of, you know, next steps, when to get MRIs, and other things like that. So if you do or are interested in receiving that, please come to Trina or I, and we'll be happy to share that with you. Okay, we'll bring up Christina.
Are you going to hold it? Okay.
Okay, sounds like I'm next. So my next topic is urgent care, and I'm going to try to give a variety of urgent care situations that would be relevant for your age, whether you're very young or if you're older. The picture there, I don't know how well it shows up. I was giving Alexa a tour of the University of Iowa hospitals and clinics and showing exactly where our emergency area is. Of course, air care lands on the top of the one area, and the emergency room is actually in the back of the hospital. So urgent care planning is important at all ages and can occur at all ages. But typically, especially for the very young, it's prompted by something that is medically intense. That might be a surgery, or it could be an intervention or a treatment that you're undergoing that would cause more urgent care situations. So in our clinics, most recently for the younger kids, that has been new medications and the side effects of those medications and how they might cause enough symptoms that you would need to present to an emergency room. Though your risk of an emergency situation increases with age, and that relates to the progression of Duchenne and the symptoms that come with it. And the other piece that I'll comment on is that not all emergencies are medical emergencies. Living in Iowa and entering tornado season and derechos coming through without warning presents a whole nother area of emergency planning that is not necessarily part of our typical conversations in clinic. I'm giving examples of some of the resources that are available and links at the very end of this, and my understanding is you'll get copies of the slides through the links after the recording. So one of the most important emergency planning tools that you have is actually carried in your pocket or your purse, and that's your smartphone or your smartwatch. These can be obviously used for calling for help when you need help, but they also can carry a fair amount of medical information that you would need in the setting of an emergency. ICE in this situation is in case of emergency, and this is an area on your phone that most phones come preloaded with a health app or some other app on there that keeps track of your steps, it keeps track of your heart rate. So if you're attached to a smartphone. So this is another place, though, that has an area where you can enter your contacts, and many of these apps also include the ability for you to add your medications that you're on, your primary medical diagnoses, and Even when your phone is at rest, there's your emergency care providers, like an ambulance person, could open up that ice in order to find your emergency contacts and specific information that's relevant for your urgent care. The other thing that can be put on your phone is the MyChart app. Many clinics, ours uses Epic, MyChart, and many of the other services and clinics that you attend has access to Epic and MyChart. So if you were in the emergency room and they needed to know more about your medical condition, they could either look through Care Everywhere, that's where doctors and nurses can look at some other institutions' medical records about you. Sometimes there's, though, difficulty for us accessing those in an emergency situation. So having MyChart on your phone, you actually can show them information that they might ask you about. There is also DMD-specific information associated with medical alert bracelets. You can get a generic medical alert bracelet that tells your diagnosis. There is also then the Cure Duchenne has a medical alert bracelet that when you flip it over, it has a QR code reader. It brings up Duchenne muscular dystrophy care guidelines specific to emergency care if you're in the emergency room. Where's the young fix? Aren't you the one that had it at the pond? There was somebody that went down, their kid went down to the pond fishing with their buddy, and all of a sudden mom had an alert that there was an emergency. And as it turns out, the friend was just wanting to see how the QR code read. So not all emergencies are actual emergencies. So the other thing your phone can be used for is support aid. In an emergency, many of us panic, but if you call 911 and have your smartphone available, they can help talk you through the emergency. So I'm not trying to advocate that all young people should be carrying a phone because it can be a distraction. It's not appropriate in school, all of these reasons for not having a phone. But there are circumstances that having a smartphone or a watch can be beneficial to you. Again, like the watches can help with EKGs. You can also set reminders to take your medications. So there's a lot of uses for them, as well as the weather alerts. So now I'm going to make some comments about some of the other common areas that we think about in terms of urgent care planning. Steroids is appropriate for all ages in Duchenne muscular dystrophy. Those who are taking steroids, and those include prednisone, prednisolone, deflazacort, Emflaza, vamorolone, Agamree. If you are prescribed a steroid, you should never stop taking those suddenly, ever. This should be a plan that you make with your physician to taper off of them if you're changing. So it's important that you get your refills on time. We just recently had a situation where people were getting their medications shipped through FedEx, and unfortunately there was storms that went through the area, so people had a delay in getting their medications. So you are impacted by the weather and shipment and flooding and all these other things, so it's important for you to also have a backup prescription that you can get at your local pharmacy with a different, like even if you're taking vamorolone or you're taking deflazacort, that you could get a backup of prednisone. The other topic that we talk about frequently in clinic about not stopping is that if you have a stress to your body, bodily stress, and that is where you either have a severe accident, you're going to have a big surgery, you're going to have, or you have the flu with a very high fever that's lasting for a long time and you're vomiting. If your body's experiencing bodily stress, your body's natural ability to make steroids is not ready to ramp up that quickly, and you may need additional doses of steroids. So that's called stress dose coverage. And typically the stress dose coverage is not using your deflazacort or your Agamree if you're taking those, partly because you're dispensed a 30-day or 28-day supply and you don't have extra of those doses on hand. So typically stress dose coverage is with prednisone or prednisolone. If you're vomiting or if you're undergoing anesthesia where you're not allowed to swallow things, then that medication is going to be provided to you by an IV. And so when you come into an emergency situation, you should be letting them know that you are taking a steroid and having a conversation with the doctor in front of you that you might need stress dose coverage. And then you also have the ability to contact your neuromuscular clinic and ask about the appropriateness of adding stress dose coverage. Not all situations require it. A common one, though, that is not necessarily an emergency is getting your wisdom teeth extracted when you're a teenager. That's a situation where we might consider giving you extra steroids even. Some of the signs and symptoms of adrenal insufficiency include vomiting, low blood pressure, low glucose, altered level of consciousness, confusion. So these are all very vague things, and in the setting of being sick, it's sometimes hard to differentiate what's actually happening. The other topic that comes up regarding steroids is that the steroids themselves can cause stomach ulcers or upset stomach, which could cause you to go to an urgent care, or the steroids, as I talk about in the next slide, relate to fractures and bone fragility. So fractures or broken bones. Boys with Duchenne are naturally at higher risk for fractures. Partly because you're less mobile and less active, your bones become a little weaker or have osteopenia. In addition to that, when we add steroids onto your health care, that adds another layer of bone fragility or low bone density. As the disease progresses and you become weaker, you tend to have falls more frequently, and as you fall, you may injure the bones and have a fracture. Fractures can also happen with transfers. Even if you're using a Hoyer device, you can have the sling fall, or you hit the tub or shower in a bad way and you have an injury. The other part to that is like when you have a sudden drop, you may actually compress the spinal column, and those bones of the spine can cause or be compressed and have a compression fracture. So if you have pain in your spine after falling or a hard transfer, it might be an indication to have it evaluated with an x-ray. If you have a broken bone that's part of your limb, like you break your femur bone, there's a lot at stake to getting you up and moving and walking again if you are currently walking. So sometimes the management might include a discussion about whether or not to surgically correct the bone rather than just putting a heavy cast on. If you've ever had a broken bone, worn a cast, for everyone coming out of a cast, those muscles have atrophied because they've been not in movement for a long period of time. In a guy with Duchenne, losing that additional muscle strength can be very difficult to regain over time. So sometimes a surgical procedure where they put plates or screws and bolts, hardware, in there to secure the bone, you might be able to become weight-bearing earlier than if you were just casted. There is another extremely rare situation that can happen even if the bone is not clearly fractured but has an injury to it. This is rare. It's been talked about a lot in social media and across a lot of the different Duchenne platforms. It's called fat embolism syndrome. This is following an injury to the long bone. Some of the symptoms might include shortness of breath, altered alertness or altered conscious, and then a rash or petechiae, which has like these pinpoint rash typically across the chest. This is where the bone has leaked some fat out of your bone marrow into your bloodstream, and those globules of fat can travel throughout the body and land in an organ like the lungs or even travel to the brain, causing like a stroke-like picture. So this is clearly an emergency where you have to go to, it's probably by ambulance. The management is kind of symptom-based. There's not a lot we can do to prevent it, and there's not a lot that we do differently other than just support the individual with IV fluids and all the things to try to get them back to being healthy. If you have a fracture of any of your bones, if you have not already seen an endocrinologist, that's typically the person who manages this part of bone health. In some clinics, that might be an orthopedics service, but most of the time it's an endocrinologist. I would also say that if you have an injury to one of your bones and you're needing to rehabilitate, you should be working closely with a physical therapist to make sure we're optimizing your ability to rehab. If you have a medical emergency and you're presenting to the emergency room, it's possible you'll need anesthesia, either because you're facing a procedure that needs to be done while you're sedated, or you're possibly facing a surgery. It's important not only that you tell the surgeon who's treating you that you have Duchenne muscular dystrophy, but also the anesthesiologist, making sure that the entire team working with you is aware of your underlying medical condition. As anesthesiologists go through years and years of training, they know that individuals with neuromuscular conditions, including Duchenne, need to avoid certain kinds of anesthesia. If you are getting a nerve block, that's generally considered to be safe because it's not part of general anesthesia. And then laughing gas that you might get if you're in the doctor's office is also generally considered to be safe. However, there are other forms of anesthesia that are inhaled that are not as safe. And so we recommend, as a general statement, that you avoid inhaled anesthesia if at all possible. In an emergency, they need to do everything possible to keep you alive. So sometimes things get used when it's maybe not the best choice for you at having Duchenne, but they're working with what's happening in the moment. Guys with Duchenne have an increased sensitivity to some kinds of muscle relaxants, and that's a common one that I'm listing there as one to avoid. Again, this is a situation that they need to know that if you're going to be prolonged not eating by mouth, where you take your steroid pills, that then they need to remember to convert that, to give it to your steroids to you by IV. And this is putting kind of a lot on you as caregivers to remember these things, but I'm telling you that unfortunately many times in a medical setting, these things get forgotten and they're not asked or cared for in a timely manner. If you know that you're going to undergo surgery, it's helpful to have a preoperative assessment. This is where they identify any risk that might be related to your cardiac, meaning your heart, or your pulmonary, meaning your breathing, that would place you at increased risk. Some guys with Duchenne have difficult intubation. That's where they put the tube down in through your throat and it goes in to help support your breathing. Large tongues, small oral openings. There's a variety, maybe you had spine fusion and your neck doesn't move a lot of different directions. It can make it more difficult in an emergency to put the tube down into your throat, into your lungs, not into your esophagus. If you have undergone anesthesia, many times it's important to extubate, meaning when they take the tube out, to support you on your BiPAP because the effects of anesthesia can be long-lasting and suppress your ability to breathe on your own. So we usually say that your breathing needs to be supported until you're fully awake and capable to communicate on your own. If you're advanced, like the older guys with Duchenne, or younger, if you have cardiac problems known already, many times we'll recommend cardiac anesthesia. That's where they have anesthesiologists that are more aware and following not just the EKGs and how you're doing under the anesthesia, but making sure that you're not fluid overload, adding the strain on your heart. Throughout any type of anesthesia, there's a lot of laboratory monitoring that happens. And then in follow-up of some sort of anesthesia or a procedure, if you're taking pain medications, we need to be very cautious that it's not suppressing your respiratory drive. Some of those medications can also cause reflux. If you're refluxing and you're not fully awake, you might aspirate. That means take the contents that are in your stomach that come up into your lungs. And then some of those pain management medications can also cause constipation, which boys with Duchenne and guys with Duchenne are at risk for anyway. So I'm talking a little bit already about respiratory. This has historically been one of the most worrisome areas in terms of urgent care, but this has to do with both your ability to breathe and the ability to cough. So chronically, meaning over the long haul, over the long period of time, as your disease progresses, your muscles of breathing, that's your muscles of your trunk, the intercostals, as well as your diaphragm that takes the air in and lets it passively go out, become weak. When that happens, this is known as hypoventilation, meaning low breathing. Over time, if your lung volumes are going down, you might not be pulling in as much air as you used to. In addition to that, you might be retaining CO2 or carbon dioxide. And that's actually sometimes the more problematic part of this process. In addition to that, because you don't take in as large amount of breath to make a cough, like all of us, if you're going to go to cough, what's the first thing you do? you have to take in first the big breath to cough. But if you can't take in a big breath, your cough is ineffective, and it's mostly clearing out the back of your throat. So this puts you at risk for infection in a term called atelectasis. It's where the little insides parts of your lungs collapse, and in those areas it's not able to exchange the gas from the air and take it into your lungs and then get oxygen into your bloodstream and then blow out the CO2. The subtle signs of chronic or long-term hypoventilation include morning headaches, fatigue, daytime sleepiness, reduced appetite, weight loss, just not feeling well, and breathing just feels more difficult. Sometimes this is hard to know in guys with Duchenne if they're having labored breathing. For some of us, like if I went and ran a marathon, I'd be, yeah, this is really hard on me. But if you're sitting in a wheelchair, labored breathing can be more difficult to observe by someone else. So then we get back to kind of the more acute or urgent type of respiratory problem. So underlying is the chronic illness of hypoventilation, but then you can have an acute respiratory infection. The signs and symptoms might look similarly, but you're more likely to have a fever, maybe have more secretions, and a more rapid onset. So in a respiratory illness situation, if you are not already on BiPAP or AVAPs, those are the machines that support your breathing, you might expect to start these. We try to get ahead of this process if we recognize that you have a weak cough, and the doctors prescribe a cough assist device, which helps to inflate the lungs to keep them healthy and wide open, as well as then a secondary setting that simulates a cough, making a big breath in and then quickly exhaling, simulating the cough. So the cough assist is really prescribed daily to maintain the lung function. And then BiPAP may be recommended after you start to have respiratory infections, because that might be a symptom that your lungs are having that atelectasis and areas that are ripe and rich for chronic infections. Just a note that there's another machine similar to BiPAP that's called CPAP. So the CPAP stands for continuous positive air pressure. That's where the machine is used for sleep apnea, where it helps to open your airway, your soft tissue area, so that you can take your breath in and out while you're sleeping, especially. BiPAP is bi-level positive air pressure, where it gives you a little bit of that pressure to open up your lungs, but then when you take a breath, it naturally fills the rest of your lung volume to support your breathing. When you're having these kinds of emergencies, CPAP is not the kind of intervention that you need. You need the BiPAP, or when you're seeing a pulmonologist, they might actually use a different kind of machine called an AVAPS. If you are already prescribed BiPAP or AVAPS and you have a respiratory infection, you need to wear your BiPAP or your AVAPs on the way to go get your medical emergency care. This is because we already know that you're having struggles to breathing if you're needing to seek urgent care, and the number one intervention that needs to be added is your BiPAP, that's to support your breathing, and a cough assist device to clear your airway. So don't assume that when you get in the ambulance that those things are going to be available, because they typically are not. Now, they have a suction machine usually in there, and they have ambu bags that can help with your breathing. But if you are already having those devices, bring them with you. The other thing you should know is that when you get into the emergency room, they have a respiratory therapist on staff, but they don't necessarily come into your room and recognize that you need those things to stay healthy. So take yours with you, use them. The people that are interacting with you may not fully know your settings, and so it can also be helpful to know your own personal settings on your devices, which I realize a lot of you don't know those. The last thing in this area that I think I'm going to mention is that if you go into an emergency room, particularly if you are already using BiPAP, you should not just be given oxygen. You need to have air intake. And so you can put all the oxygen around your mouth and nose that you want, but if you don't have the ability to take a breath and pull it in, it's not going to do you any good. So you need to take your BiPAP machine so that is allowing you to take breath in and, of course, passively let it out. So in general, we do not recommend oxygen use without ventilation. And a blood gas could actually be helpful in this situation. We don't tell doctors in the emergency rooms what to do, but a blood gas is probably a reasonable test to be looking at if you're going to the emergency room for breathing problems. Problems with the heart typically do not present problems that would take you to the emergency room until at least the second decade of life. There are some that have earlier onset, so that's just a general statement. More heart problems are typically associated with a little bit later in the disease. Our key focus is really about early detection and monitoring, and this is for all ages. We're seeing you in clinic. We get EKGs, echoes, or cardiac MRI. And the prevention is that we start medications to try to slow or prevent the onset of cardiac problems. However, that being said, chest pain is a fairly common complaint. And if you have chest pain, by all means, it's hard to know what that chest pain is coming from over the phone if you're talking to somebody. So if you think you're having chest pain and you don't know what it is and it's brand new to you, you should probably go to the emergency room and see what it is. So things that might cause chest pain besides the heart are esophagitis, that's like heartburn, muscle strain, pneumonia, and actually, like a myocardial injury is like a heart attack. That's not a very typical thing to happen in young people and not a super common thing in Duchenne. However, as you develop cardiomyopathy, you can develop chest pain as well as palpitations or flip-flopping, funny feelings in your chest. All of those things should be evaluated. Some things to consider when you're in the emergency room for chest pain is that the CK is always elevated. That used to be kind of a marker that they look to see if you're having a heart attack. So somebody coming in would get CK as one of the lab values that they're looking at. Most of the time you don't have to remind the providers that are working with you that is not a good indicator for muscular dystrophy, but occasionally it still happens. They are likely to do an EKG to see what your heart rhythm looks like. It is very common for EKGs to be abnormal in Duchenne at baseline. So they're going to want to compare what did it used to look like when you were back on your clinic visit 6 months ago. So if you have Epic, again, you can probably pull that up. They might be able to pull it up if they use the same electronic system. Some of the advocacy organizations recommend that you carry a copy of your EKG, but I think it's really hard to keep that current. So there's some nuances there. Typically, if they're asking about these things, you are pretty stable in the emergency room and they have time to reach out and ask for us to fax them a copy. So you can also then ask for a cardiologist familiar with muscular dystrophy. Depending on what ER you go to, you may not have that availability. But if you're visiting the ER for chest pain, probably you should follow up with your cardiology team. And again, this is a situation where ideally, if you're coming in with an illness or specifically if you have chest pain and you know you have cardiomyopathy, overloading with fluids is not maybe the best thing. The next area is abdominal pain, and really this is kind of covering GI, gastrointestinal, and GU, which is the urinary system. There are many, again, causes for abdominal pain. One of the more common is constipation. So if you know you are not going to the bathroom every day, or maybe you're not going but every 4 and 5 days, you're going to end up with belly pain. And the longer you let that build up, the more problematic it's going to be. So it's recommended that you use preventative measures and keeping bowel movements going regularly. Other reasons for abdominal pain are the flu and viral illness. Usually those are accompanied by a fever and you know why you're going to the emergency room. Other reasons could be an esophagitis or an ulcer. Sometimes those are side effects of the medication. Gene therapy could be a cause of your abdominal pain, and in that situation, if you've had gene therapy, you should be calling the person who prescribed it immediately. Those are side effects that need to be reported and have a follow-up plan. And for anybody that gets gene therapy through our clinic, they're provided with a cell phone or a pager to reach those people. Just because you have Duchenne doesn't mean you're not at risk for anything else, and those include things like appendicitis. Kidney stones are more common in the older guys with Duchenne. That has a little bit to do with immobility. And then ileus or bowel blockage is becoming quite common in older guys with Duchenne. It's kind of a combination of many chronic problems. But again, if you're not having regular bowel movements or if you're having bloating in the abdomen, they can be talked about in your regular appointments. But if it's bringing you to the emergency room, you're likely to need follow-up with the gastroenterology specialist. So again, prevention and early intervention reduce the risk of urgent care for constipation and esophagitis. Some of these others don't really have preventative opportunities. So this talk, fact sheets, pocket guides, social media, and all other forms of communication outside of your regular doctors are not substitutes for medical assessment and recommendations. If you feel like you're having an emergency, go to the emergency room. If you feel like you're having ongoing problems, talk with your primary doctors and your neuromuscular specialists. Some of the other areas of prevention and preparedness for emergencies is to stay up to date on vaccines. We knew back in COVID when all of a sudden we had this breakout, who didn't have vaccinations, who did. We now have a measles outbreak. So, if you're not up to date on your vaccinations that would prevent or lessen some of these effects, that can be one good strategy to prevent a trip to the emergency room. If you use a wheelchair, you must use seatbelts. It's very common for people to come to the edge of the curb or hit a bump and be tipped and tousled and can't catch themselves quite quickly enough and topple outside of their chair, and that can cause a broken leg. You should have emergency evacuation plans and know where you're going to go for a storm at home, work, and at school. We learned in the derecho for here in Iowa and Nebraska that there can be power outages that last for a very long time. So if at all possible, it would be good for you to own a generator. The generator can charge your power wheelchair. For those of you who only have a power wheelchair and you lose power and you can't charge it, it can make it very difficult to get around. Similarly, if you use respiratory devices, those need to be charged as well. You can also notify your electric company that you have someone in your household that requires power restored. They don't necessarily have the ability to prioritize you, but they can at least be aware of you and do courtesy checks to make sure you're doing okay. The last couple of things is making sure you have your important medical information in one place. This includes the names, phone numbers, and list of people to notify in case of emergency. Some of these things include a medical summary. This is a formal list of diagnoses, allergies, meds, provider names, your durable medical equipment people. All of those things are available in your MyChart or on your after-visit summary. But sometimes, and your clinical notes oftentimes summarize everything that's been recently going on with you. But it doesn't always, not every note has all of those details in it. So there are tools that you can use to make your own medical summary so that those are available to you. And then as you get older, in adult life with Duchenne, there might be additional documentation that you need to have readily available. Those include an urgent care plan if you have something written out saying this is how you treat respiratory illness. Advanced directives, which is a legally binding statement for how you would want to be treated if you're at the end of life. And then other documents like the provider order for scope of treatment. This includes things that you would want done in an emergency and what you would not want done in an emergency. So sometimes you're coming in and you've never met the emergency room provider. They might make an assumption that you don't want things done. So this is an opportunity to say, no, I do want things done, and this is the order and sequence of doing those interventions. There's other things, healthcare, power of attorney, living wills, and organ donor status as well. This is links to some of the advocacy organizations, emergency preparedness recommendations, emergency funds, guidelines, things that you can use to communicate with your primary care provider, as well as emergency room providers.
Please feel free to continue eating, and here's Diane.
Thank you. And this is the clicker, right?
Yes. So green is forward, red is back. And you don't have to point it at anything.
Just click it. Okay. How was lunch? Good. Good. Well, I'm grateful to be here today. Whoops. It's good she told me what back is. There. I'd like to tell you about our division of the University of Iowa a little bit, and then focus especially on some family trainings that we do, in particular one called digital storytelling, and then I'm going to invite you and your youth to take part in it if it appeals to you. So a little bit about Child Health Specialty Clinics. We are a division of PEDS at the Iowa Health Care, but we're not in Iowa City. We have regional centers throughout the state in underserved areas. We provide gap-filling services like an ARNP, a nurse, and a family navigator. And there is a brochure on your desk that has a map if you're curious if there's a regional center in your area. These regional centers started many, many years ago, and since then we got the grant called Title V, which is a partnership between the federal government and the state government, and we have the slice that is for children and youth with special health care needs, which is a maternal child health, long way of saying disabilities. So those are some of the things that we do, and you'll hear me say children and youth with special health care needs because I'm used to it. But this is, as I said, the federal government uses this in the maternal child health funding world. And it is anybody who needs more health care than a typically developing child, or is at risk of needing more health care than a typically developing child. We have approximately 143,000 in Iowa that fit in that category. And you can see some of the categories that Child Health Specialty Clinics can work with. Our agency has priorities for, we want to provide access to community-based services and supports, including telehealth. One of the helpful things about our regional centers is if you need to see a psychiatrist in Iowa City, but you live in Sioux Center, you can go to the regional center there and receive telehealth through their setup. So that's been a nice thing. We also have a priority of supporting families through transition, and I see a lot of young 14 and older youth here, and that we call that the transition to adult health care age. So it's different than when you're a child and your parents do everything for you. But as you become this age, you start to think about, okay, how do I advocate for myself? How do I talk to my providers? How do I get my prescriptions refilled? How do I make it to my medical appointments as you become an adult? So that's what transition means. And then we support parents who are parenting children with a special health care needs. The CHSC hires families who have lived experience of raising a child with special health care needs. It's a great thing because they often will employ us at 50% time but give us full benefits, which is a great way to take care of our medically complex child while working and receiving health care. And what we do, we're called family navigators, and we reach out and support other families, even if we don't have the same diagnosis, to help them find resources in the state and to help navigate the system of care that we have in our state and also provide emotional support. So if you'd like to know more about family navigators, or if you'd like to have one, the brochure is there on your desk, and also my card. We'd be happy to have you reach out. And I did serve as a family navigator for a while, but now I'm the director of family training. So there's some of the things that we do. I wanted to, Christine asked if I could tell just a few things, a few of the programs. So we do have an autism program called RAP, Regional Autism Assistance Program. We have an early access program. These are service coordinators who help early intervention, birth to 3. So it's provided by the state, just like special education would be in schools, but this is for at home. So the therapists and teachers come to your home birth to 3, because we know that early intervention helps many disabilities get a leg up. And so CHSC has a couple of service providers, and there are others that work for the AEAs that are not CHSC, but we share in that grant. And then we have a pediatric mental health grant where we offer monthly webinars to pediatricians and primary care providers about different disabilities that children might have to help them in becoming more comfortable treating and providing care for. And then this is my area, the family leadership area, and it's called Iowa Family Leadership Training Institute. We offer storytelling trainings and also educational webinars. So the one I want to tell you, so I'll start with Iowa Family Leadership Training Institute. This is a 4 or 5 month weekend, once a month training that offers parents a chance to learn the history of disability advocacy, grow in their self-awareness as a leader. Often we have to convince families that yes, they in fact are leaders. And this is for families who have sort of settled things at home with their child, and they're looking around and saying, I think we could make our state better for kids with disabilities. What could I do? So that's where the community leadership or maybe state leadership comes in. So that's what that training is about. We practice talking to legislators. We learn about civics, advocacy, conflict, communication, resilience, self-care. And so if you're interested as a parent in taking that training, it's offered every spring. And we'd love to have you apply. Under that big umbrella are 2 storytelling trainings. One is called digital storytelling, and one is storytelling for family leaders. Jen is here, and she's a grad of the storytelling for family leaders. This is a hybrid in-person, online training where families prepare this 10-minute speech where they're ready to share with providers, school boards, civic groups about a special healthcare need that needs people to be aware and raise awareness. And then digital storytelling is the one I want to tell you about today. Our trainers, we have 4 trainers, and I wasn't organized enough to get all 4 pictures there. So these are 2 of them. I am one, and Sean is one. And we are family members who are really families training families. So we all have that lived experience. So digital storytelling, our teachers were the Story Center, which is an organization out of Berkeley, California, that aims to teach people how to tell stories for awareness in their communities. Many of their stories are centered around marginalized people groups. And if you look at Story Center on the web, you can see some of those digital stories. So they trained us in 2017 to adapt this training for families of children with disabilities. The objectives of the training is to honor the life experience of the storyteller. And this, up to this point, has been the parent or the family caregiver. To provide an experience that allows for reflection and transformation. For many families, when they get the diagnosis, a flurry of studying and learning everything you can and going to conferences, and there's not a lot of time to sit back and reflect on, wow, my life took a different turn than I was expecting. And so this training, this storytelling experience can be an opportunity to stop and reflect on that. It can bring your life experiences to new life in an artful way. And the people who join together create a community and a bond, because oftentimes families can feel isolated. And when they're together with other families, just like you are here today, it can be a really rich, empowering experience. And then, of course, there's the advocacy piece. We want digital stories out there because it raises awareness and can create change when people know. A family story has a lot of power. And when it's paired with visuals, its impact can become even stronger. A compelling story can raise awareness, promote acceptance, drive meaningful change in a system of care. One of our grads worked with this representative, Ann Meyer, who is from the Carroll area. She's leads the legislative committee on health and human services, so she's really into our area. And our grad approached her with a picture of her child being changed on the floor of a dirty bathroom. I don't know if you have thought about it, but when you go to public restrooms and you see the changing table, it's the size of a baby, right? Well, there are adult-sized, adjustable changing tables that people can put in that are for people who are larger than babies and need assistance with their toileting. Representative Meyer had no idea that these existed or that this was a problem for parents because she hadn't heard about it until a family member came, showed her a picture, and told her a story. She was so compelled by this story that she introduced legislation in the Iowa legislature to make these mandatory in all public spaces. The actual law itself didn't pass because the Department of Transportation stepped in before then and said, this is a no-brainer. Of course we're going to put these in all rest stops along Highway 80 and other places. And so that family story really sparked an awareness in Iowa, and it has a lot of potential to grow. If you've never heard of them, there's an organization called Changing Spaces that works on bringing these adult-sized adjustable trading spaces to changing tables to places where families can't stay very long because they have to go home. And if an adult-sized changing table is at a park or at the state fair or at the zoo, the family can spend the day. So the family story is very powerful, and that's one of our favorite examples. Digital storytelling is a powerful tool that uses that family story to create connections, build empathy, and inspire action. And you know, as humans, we love stories. If you're listening to a speaker like me and they get to a point where they're going to tell a story, you kind of put down your fork and start listening, right? We're drawn to stories, and we love those. And so that's what digital stories can do for people. Parents of kids with disabilities can often feel isolated and alone, and being able to tell your story with people who understand that experience brings hope and resilience. Excuse me. It allows people to see the difficult things that they've overcome to get where they are now on their journey. Digital storytelling is designed then to help families bring their story to life in a 2 to 4 minute digital story that can be used for advocacy purposes or to raise awareness. This program is designed specifically for families of children and youth with special health care needs. And the storytelling process, as I said, is not only reflective and transformative to the parent as they reflect on how their journey shaped them, but it also highlights the power and the impact of the family voice in helping each of us to become more aware of the struggles and triumphs of children and youth with special health care needs. I'd like to tell you a little bit about the training, and then I'd like to show you an example. So when you come to this 2.5-day training, there's 2 overnights, we first learn about the 7 steps of storytelling from the Story Center. You participate in a story circle that helps you sort of find the story that you want to tell. We are using the WeVideo platform. Maybe some of you have used that online, and that we get trained in that. And then there's work time to write the story, record the voiceover, and add the visuals. There's a one-on-one mentor, and at the end of the 2.5 days, we have a premiere with invited guests. So this is one of our grads that created this story, and I'm hoping the sound and everything is turned on so you can hear it. You might have to run it from back there. it's hyperlinked, so if you press, whoops, no. Sometimes if you go out of the PowerPoint itself, then you can find the YouTube link a little better.
I haven't
It
always
is on
had-
YouTube, so if you search YouTube for Iowa Family Leadership Training Institute, we have about 40 digital stories there, and this is one of those. And so if we can't see it today, we could also search YouTube to find
I haven't
it.
always used my voice. Our voice has power, but I felt like I had none. Our voice gives meaning, but I felt lost. Our voice allows us to be seen and heard, but I was so used to being silent, insecure, and afraid of rejection.
I apologize, I should have checked with
Learning
you.
to be an
Here it is. Yeah.
I haven't always had a voice. Or should I say, I haven't always used my voice. Our voice has power, but I felt like I had none. Our voice gives meaning, but I felt lost. Our voice allows us to be seen and heard, but I was so used to being silent, insecure, and afraid of rejection. Learning to be an advocate for my daughter challenged me in ways I never envisioned. I felt an internal pressure to learn and know a world that was foreign to me, to make the right choices, to be the voice for my daughter. Thinking about using my voice never felt powerful or meaningful. I was battling against the voices telling me to know my place, to be quiet, to not ruffle any feathers or make any waves. I didn't want to appear as a needy, ungrateful problem starter. I didn't want my daughter to be a target because of how I was or wasn't showing up. And yet, I knew I wanted to show up for her, to be her voice. The room was chilly. Sitting around a table with school professionals, special education and intervention staff with bright hospital white lights glaring down on me. My heart was pounding, nearly beating out of my chest. I feel like she needs more. Did I just do it? Had I just made a subtle hint, a near request that my daughter needed more? I felt like more services were needed for her, but no one else was making this suggestion. The people who knew more than me in deaf education and the people who were supposed to be ensuring she had access to the resources she needed hadn't suggested anything. Should I have kept my mouth shut? But my voice was heard. This was the pivot that changed her access to resources and paved the way for immense growth over the next several years. Our team of professionals may not always see the gaps or know the specific needs our child has at different times in their lives. Wrestling with the belief of needing to look, sound, and behave a certain way ultimately gave me permission to go to battle with my internal dialogue and how I was showing up or not showing up. I started practicing vulnerability, asking questions, and speaking up and showing up. She needed me to ask for what hadn't been offered. My voice has power, gives meaning, allows me to be seen and heard. My voice creates the foundation for her to use her voice, for her to be seen, be heard, and to fill the silence.
Best and worst dinner for your...
So that's an example of a digital story. Jillian Kaufman created that one. She's from the Quad Cities area. So as parents, if you're interested in creating that kind of story, we'd be delighted to have you in our trainings. We use these stories for social media. You can use it to email to a legislator. You can share it with family and friends, any place that needs a growing awareness of your life with Duchenne. The DD Council recently did a presentation using and showing those some digital stories of ours for Disability Awareness Month. So we were hoping a bunch of legislators would come. Not so many did, but we keep up the effort. So the next place here has a little quote from a grad. Learning to tell a story using a digital format was unlike anything I'd ever done before. It helped me really focus on what was important about the story and how to use images and sounds to create the emotional impact. I've told many about this amazing class. If you're thinking about taking it, just do it. So in November 5, 6, and 7, I believe, is when we have it scheduled this year, and it will be in the Des Moines area. And there's a my card on the tables there, and you'll see some promotion and about it on the IFLTI Facebook page and also on our website when applications open. But then this year, I'd like to tell you about a pilot we're doing. We'd like to see if we can train youth with Duchenne who would like to create a digital story. You know, they're all digital people anyway, and we think it won't be hard to teach them to use the WeVideo platform because they probably have already used it. So this summer in June, it'll be virtual. We're going to select among applicants a small group to see if this is something that will translate to youth, and then we'll ask them to give us feedback about, did this work for youth? We're used to training families, we're not used to training youth, so we'll need their feedback and how we could improve it. If your child is interested or you want to tell them about it, there's a flyer on your desk that looks like this. You can scan the code to apply, and we're selecting those people now, so we'd love to have your youth apply. Are there any questions about family training, child health specialty clinics, digital storytelling? Yes, covered by the Title V grant provided by Iowa, sadly. Are you close? Yeah. Yes, yes. We wish. Mm-hmm.
You mentioned their overnights.
Yes.
If we have somebody we have to take care of at night, do we have to do the overnights, or if we live close, can we come and go during?
Yes, some of the folks who've lived close to Des Moines actually go home. Mm-hmm. Yeah, so you don't. The only thing we recommend is that you clear that time the best you can, because folks really use the overnight to cook the story and really decide what it is they want to do.
I don't sleep anyway, so.
Okay, so you'll be good. Yeah, good. Any other questions? Okay. I think we're in for a treat with some family stories next. Thank you for your time.
All right, so we are going to have our All right.
Okay, so in advance to prompt discussion, we proposed a couple of questions just to get the thoughts churning here. Oh yeah,
I'll do it.
Yeah, you do it.
So I want them to introduce themselves, tell us a little bit about you guys. I know you told us we didn't get to hear all about you, Nick, but Tucker was able to share about who he was. But can you just share a little bit about yourselves, your hobbies, what you guys like to do, and how old you guys are? Yeah, no, I'm just kidding. Go ahead, Tucker.
So I'm Tucker Hart. I am 27 years old. I work at John Deere full-time, so that occupies most of my time during the week. I'm a big NASCAR fan, so I watch a lot of that on the weekends. I also watch a lot of golf. That's something I've kind of got into the last couple years. And then I also have a 3D printer that I mess around with quite frequently and make fun things with that. So it's a little bit about me.
2 questions to that. What do you do at John Deere? Because that's awesome. And what kind of things do you make in 3D printing? And I only ask because we just did a webinar on it, so I'm super curious.
So at John Deere, I'm on the continuous improvement engineering team. And so we look at like issues with parts and assembly problems and fix those. And also looking at warranty problems that we might have and come up with design solutions for those. And then with my 3D printer, most recently it's been a lot of like phone stands and a lot of like little signs and just kind of things that aren't necessarily useful most of the time, but I have enjoyment with that.
But fun to make.
Yeah.
All right, Nick, what about you?
Hi, I'm Nick. I'm 22. I'm graduating from William Penn in a few weeks, actually, in new media. So I'll get my my bachelor's in that. So.
That's exciting.
And did I say where it is from?
I don't know. Did you go ahead and say
Oh,
it
I'm
again?
from Pella. So Tulip Festival. If you're in from Iowa, I try to avoid, but sometimes I go for food. But that's it. What I like to do for fun, I like watching sports, Hawkeyes and Vikings, and Cardinals for baseball. So, and I like play video games and watch movies and family and friends time. So, and I also have 2 dogs.
Awesome.
And a horse.
Perfect. All right, Lisa, you're up.
Okay.
You don't have to tell us how old you are, but.
I first want to know, what's your favorite NASCAR driver?
Currently, it's Noah Gregson.
Oh,
I was
don't know him.
a Kevin Harvick fan for the longest time, but he's retired now. So.
Oh, okay. And what kind of video games do you like to play?
Madden and like Call of Duty sometimes.
Ooh, we're going to have to get you and Ethan, because he likes both of those too. My name's Lisa Huntley, and I am kind of a quandary for this group because, number one, I'm 59 for a couple more months. But I am a grandparent, but I'm also raising. So I get both ends of the stick. I can be a grandma when we want to do fun stuff, and then I am the parent when it's take your meds and brush your teeth and do that kind of stuff. I think Ethan was diagnosed at 4, so 10 years, 11 years in the community. Jet Foundation, PPMD, Cure Duchenne. I encourage all of you to get involved with their Facebook pages and their groups, because you can get so much information from other parents, just hearing their ideas or bouncing ideas off of each other. I go to Ethan's doctor's appointments with him, so I am the one that has all of the information in my head. Mom and Dad are just kind of like taking him there, and I get to do all the talking. The presenter before me, I'm so sorry. Diane. Get involved with that. That's great, because we have one in Illinois, because we're from the Chicago area, and it's called DCSS. And they call us monthly. They pay for our hotel bill when we have to go to the doctor. They will help with home modifications. They will help with IEPs. Anything that you can get information from and use it, do it. I am like 3,000 people on my Facebook page now, and probably 2,000 of them are DMD families. So it's really nice to be able to bounce ideas off of each other. And when Ethan got sick a few years ago from taking the bone marrow, or not the bone marrow, the bone infusion, I was on the phone on Thanksgiving night at 10 p.m. to people in New Jersey, and then they had the nurse from PPMD on the line with me, because the doctors didn't want to listen to what they should do. Our area doctors didn't know anything about it, and here I am sitting in the waiting room on the phone, on speaker, with the kids in the exam room telling the doctors what to do. So information, 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 because you are teaching the doctors most of the time. They don't deal with it a lot, so the more information you have up here and written down, the better. And yeah, I love the Jet Foundation, and camp, please do camp. It's fun. Ethan got to go for the first time last year, and he loved it. So, yeah. The what? I'm sorry.
I said you were at East, but you were at Southeast last year.
Yes.
Which is in South Carolina. So they
Yes.
came all the way from Illinois to South Carolina. So again, it doesn't have
For a
to be
3-day weekend.
Yes.
And then we made a week vacation out of it. So we stopped in Asheville while he was in camp, and then we went to Gatlinburg after he got out of camp, and then the hurricane hit. So we were good. We were there the week before. It was like, woohoo. But these boys are amazing. Smart, intelligent, witty, and sometimes a pain in the butt. And the steroids usually do that. So
They're also normal guys.
They
so.
are. They are. They're normal teenagers and young men, and you just have to go with the flow most of the time. And the equipment. Use the equipment. I'm telling you, the lifts, the seat transfers, the transfer boards, anything that you can find, use it, because it's going to save you in the end. It's going to save your back. It's going to save your arms and your brain, because a lot of times it's ow, 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 and you're like, what? I don't know what I'm doing. And, they don't take, he doesn't take pain very well, but neither do most men. So, But
All right.
That's my story.
Thank you. All right, Nick. She's going to give it back to you. Awesome.
I'm debating which question to ask first, but I think I'll start with kind of go in order of what I sent to you guys as like kind of warm-up questions. High school builds a network of peers and daily routines for over 12 years while you're in school. Tell us about social activities and work life after high school. What do you do after high school?
How many questions are you throwing at me in a row?
When you were in high school, your routine was planned out every day. You went to school, and of course you're in college, so you're still kind of doing that. But how did things change going from high school to college?
Well, I definitely didn't first few years of high school. I really wasn't thinking about that. I was just thinking each day, get through 1 year at a time, especially with high school. I think the first year, I had a teacher that just didn't understand. So of course you're gonna have struggles like that. And in the end, we had to just ask what I wanted and needed, especially for my parents too. They've definitely gave me the opportunity to say things like to speak up for yourself. And I know a lot of people have different personalities, and that might not be your thing, but that's what I was taught. So I definitely question and ask for what I need. And then, like, I finally decided, because I had a good support system, that I could do college. So, I mean, I commute every day, so that was also an issue. It was like, I had to choose a college close by. That would make it easy. So, good thing I found a good program nearby and a good support system, so.
Tucker, do you want to, you're, a few more years beyond high school and college, but do you want to just talk a little bit about that transition from being a high schooler to being a college student and then actually, becoming a full-grown adulting?
Yeah, so high school, kind of like what Nick said, I basically just try to get through each year and then kind of reevaluate and go through it again. I probably wasn't the best advocate for myself doing that, and I've noticed now that I'm a working adult, I've gotten a lot better at that, asking for what I need help with or assistance with when I'm at work. And so I've definitely grown with that. And then college was a lot of fun, so I would definitely recommend pursuing going to college. Just because of the situation doesn't mean that you can't. And so I also did choose a college close to home, and I was very fortunate enough to have a good friend of mine who was my roommate for 2 of those years that I was in college, and then I met some other people who were my roommates later on. And so it was very helpful, just meeting people and kind of understanding that, most people do generally want to help, and asking for help is totally fine, and that was something that took a long time for me to get comfortable with.
Following up on that for both of you, there's a lot of parents sitting here listening to you. I think we've lost our tweens and teens to the game room again. Oh, there you are. I see you out there. Thank you. So what advice do you have for Grayson and the rest of the people his age and the parents? Like, how can parents facilitate, encourage you to be your own advocate and to speak on your own behalf?
I'm just thinking.
Okay.
I would say let boys be boys.
You want to elaborate on that?
I guess, do the mom thing and make sure that they're doing what they're supposed to be doing, taking their medicine and doing the therapies or whatever it is. I would, strongly push that, but then also be understanding that we may not want to do those things all the time. So I guess let us have our video games and do the things that we enjoy also.
Can you repeat it? Sorry.
What advice do you have for parents to help them teach their young person to advocate for themselves? Or just any advice you'd tell parents, like, do this, don't do that?
Well, one thing I would say is, I don't know, depending on how, definitely how my mind works is, I see some and it's like, that's not a good situation to put me in. Or I'm like, at a young age, I was very, I would say,
yes.
a problem.
give one example. I would get calls that Nick was advocating for himself in the, I think, PE class, and he didn't like what the teacher was saying, and he had been told it's better to just walk away. And so he left. He completely left. The teachers were trying to tell him how.
Well, I also sat on the ground because I'm not going to curse up here, but a PE teacher that wanted me to, believe it or not, walk the mile when I was younger.
Right.
So at that point, I was like, I just didn't do it. I was like, because I had already gotten a PE note. So sometimes you're going to deal with people that aren't going to understand. But then you're going to get the people that are going to be in your life and help you. Like definitely with my caregivers, helping. You know, even though they get paid, I think they like me, right? So.
I do have a follow-up question for both of you. So not only parents, but what would you tell, boys and young men, what would your advice be? Like, Tucker, you were saying that it took you a while to start advocating for yourself. But what advice would you have, not only in college, but especially you, Tucker, going into the workforce, advocating for yourself and your needs?
I would say, first off, finding things that you're interested in and passionate about. Because when you have those things that you're very passionate about and interested in, to be able to accomplish what you might want to do in your life, it takes relationships. And to have good, honest relationships with people, you have to be open and comfortable. And sometimes your friends or coworkers might have to help you with things that you maybe don't want help with, but that's just kind of the matter of fact of the way things are for you. So I would say definitely lean into your passions and run with those.
Nick, do you have anything to add to that?
Not really. I mean, I haven't had the job experience, but yeah, it can be like sometimes difficult to ask for certain things. Like, well, I had a service dog, so that really helped too. And I know like it was a lot of work for me to get one. I had different dogs I trained with that just didn't work out. I eventually got a dog for like 9 years. He unfortunately passed this past summer. So that has been kind of a thing to deal with, but I got a new dog, so hopefully as a puppy, but so he'll have to definitely grow up and do some things with that. But also just kind of advocate, basically just try to help out the best you can. So with that, and just sometimes there's days that just are harder than others, but it's just about getting through those days because there's always good things too. So
I was going to ask about that. Could both of you comment on some of the things that you're really proud of yourself or things that were really rewarding? And Nick, I don't think you told everyone exactly what you do at your internships and your job. So could you start with that? What do you do at your internship and job?
Well, William Penn's a really small school, so I think that definitely helped with my experience in college. I don't know where Tucker you went.
You and I.
Okay, so obviously bigger school versus smaller school. So at William Penn, everything is like all sports we do student ran with the new media department and the athletic communications office. So we work closely together, and I would do a lot of like the replays for football games. So it's basically when I get set, it's really simple, like 4 or 5 buttons at a time. Wheeling back to like a joystick to go rewind and get ready for the replay. I've also done directing and technical directing. So anytime you like watch a football game and they switch to like replay situation. So there's a lot of jobs with that. So that's really what I've done. So,
And I have one question for Lisa. So as a grandparent, parent, caregiver, how do you help Ethan advocate for himself, especially as he was growing into those teen years? Like letting go a little bit of, the I need to protect him and I need to make sure that he's cared for, to letting him be himself and doing the things that regular boys do.
Part of that is attitude. When he was younger and was on steroids, the attitude was really bad. So he would get into a mood, and I would just walk away. And I'm like, this is not my fight. You do whatever you want. I do believe that when they're in school, like when he started to trip a lot, we quit PE. And we said, we're not going to do PE anymore. We're not going to try to have that hazard. Let them go. Do it. Get a wheelchair. Let them be the basketball manager, the football mascot, or, the water boy. Let them be kids with their friends. And
Did you let him make the decision to kind of
yeah.
ease out of that?
Yeah. He pretty much this last year said, I want to go back to being in PE. We're okay. And he's been basketball manager for 2 years and on student council. And I think that just standing back and letting him show his personality has kind of helped us to let him be who he wants to be. Now, he runs at the mouth, so doctor's appointments can take twice as long because he has to explain everything. So, yes, he is advocating for himself. Sometimes not the truth, but, that's what I'm there for. I just say, hey, wait a minute, that's not quite true. But, yeah, just gotta let him be.
Does anybody have questions for any three of our panelists here?
When you went away to college, what are some of the hardest things you had to overcome so that we can tell our children and grandchildren what practice on to help them get through these challenges?
So I'll just repeat, but just so if someone is watching and recording, they understand the question. But what kind of things did you overcome in college and other things that caregivers can help give advice to their child or grandchildren?
So college was probably the first time when I actually had other caregivers besides family members. And so that was a bit of a process, getting used to that, and I guess coordinating care and becoming comfortable with the people helping me. And then I would say like working with my professors, so making sure that I could get to the classrooms and having them understand that if I'm late, well, maybe it just took a while to get there, or maybe, I dropped my textbook and I couldn't pick it back up. I mean, those books are big and heavy, and they're not very user-friendly for a person like me. And so I would say working with the professors is a big thing.
Nick, what about you?
I would say based off the teachers thing, good. It's definitely good to, before you start classes, especially if they're new teachers, kind of maybe explain, might be harder for the younger kids to do it themselves, but as a parent or grandparent, it's good to have that talk with the teacher maybe, just so they understand, like, some days you might be late, because it's might take longer, so especially if someone's in a wheelchair. So, and of course it was different for me because I didn't stay on campus. Did you stay on campus, Tucker? Or were you at home?
I was on campus for my freshman year, and then the remainder I was in an apartment with 3 other guys.
So yeah, a different situation for me, but yeah, definitely getting people that can help. Because sometimes caretaker fatigue can be a problem, especially, like this gal said over here.
Not showing up? Lisa. Yes.
Yeah, like Lisa said. So that sometimes you just have to let them, if they say something, maybe just thinking how we're going to figure this out. And sometimes it might be difficult days, you know, and so you just need to step away for a moment with that. And definitely, if people want to help, let them. It might be difficult, but it can definitely help, so.
The one thing that we didn't do, because our school didn't help us with that, but as soon as they start school, get a hold of the fire department, get a pair of boots, take it to class, let all of the kids try the boots on, let them walk in them, and then tell them this is what they feel like, and so, you know, maybe they won't bully them quite as much. Yeah. Yeah. And I wished our school would let us go in and talk to the kids each year at the beginning of school. Our school didn't let us, but you know, we've dealt with some bullying. But you know, I think if you just talk to the kids and the parents, I've had to go to parents' houses and say, hey, listen, you know, we're having some issues with, you know, some teasing and bullying, and come to find out he was bullying too in his own way. But yeah, you just got to make sure that all the family members and teachers and the kids in school know what it is. And if you have to sit down with the teachers one-on-one, do it. And the IEP is definitely a major part of it, so that they, you know, they have all that. Like Ethan does not have to bring books home. He does talk to type instead of writing. There's different things that they will do for them, but if you don't tell them and they don't talk to them about it, then they won't do it.
And I would encourage, even at younger ages, like 12, when you're starting to transition into them advocating for themselves, is bringing them into those IEP meetings as well for them to start advocating for themselves. But I just wanted to mention for those, if they are listening to the recording, there is, I don't remember what the book's name is. It is like a firefighter boots type of, but we do have a list of DMD books on our website that are both written by individuals with DMD and caregivers impacted by DMD, as well as books for kids like Dan and DMD in those books as well. So if anybody needs that as a resource, please let me know and I'd be happy to direct you to that. No, I was just looking. I do have a question, and I'll take some more questions. But in terms of talking about transitions and advocating for yourself, can you both speak to, I think University of Iowa, Christina and I were talking, have a really great, you know, transition to adult program, and Christina talked a little bit about that. But as an adult going from pediatric to adult specialists, what that was like for you and how you navigated that a little bit.
I can speak on that. I guess with Dr. Matthews, I never really transitioned. Like, I still see her, and still some of the others. But like, I transitioned to adult side with pulmonary, so I go to the adult side for that. I still get the same experience. Doctor that communicates, make sure we have everything that we need, that things are still working the way they need to. So with that, that's definitely good. I would say the U of I has a definitely good feel from adult to kid side. But now obviously it comes with different things. Like I would now be admitted to the adult side. So knock on wood, we haven't had to deal with that. So, but the way the different doctors feel, it's definitely a close group and definitely know how to explain things to you. So.
Are they as nice as the pediatrics?
I would say so. I think there's been a lot of transition there, so I think they kind of understand like what comes with it. So I think that's definitely good. So.
Tucker, same experience or different experience?
So I would say for me, it was more on the cardiac front. So I was seeing cardiology locally And when I made the transition to adulthood, when I was seeing providers locally, I didn't really feel like I was much of a priority there. And so I know I've had some experience with chest pains, and I was really super worried about my heart, and so I decided that it was best to transition back to the U of I for my cardiology care. And so once I made the transition, I did feel a lot better, and I felt like the care I was getting was more, like I was more of a priority there.
And I think that's a good point, though, is if you do find that you are transitioning into adult care and are not being cared for in the way that you should be, or need to be, being able to realize that you can go find another provider that will do that for you if you need it. Does anybody else have any questions? Yes, so I will, it is on our website under resources, but I will go ahead and I'll send you the link, actually. But it is, if you go to jetfoundation.org, our resources page is a little bit difficult to navigate, but it is under the resources page. You should be able to type in DMD books, but I'll send you the link either way. Any other questions? Yep. What are the best modifications and home supports that are useful to you, especially living on your own or as an adult with Duchenne?
So I still live at home, but I still get support from caregivers other than my parents. Either if it's my sister or a family friend. So that definitely helps. And use like the lift, obviously. Like Lisa said. So, and definitely because like when I transitioned to a wheelchair, we didn't know exactly what were the best things to use for a wheelchair. So I think we just got the hang of it and make sure that comfortability is key, because that's a big one, because you can be in the chair for a lot. And I spend time, because I have an adjustable bed, so I'm not in my chair the whole day. Other than sleeping, because it's obviously hard to get on a couch like that, obviously. So, and I know those are expensive, but getting other things in a chair might be good, even if it's not an adjustable bed, a bed of some sort. And I would say just kind of figure things out. Obviously, you can ask other parents what works best. So if you can use the online forums, that's good. To kind of build on that if you're not quite sure if that's an appropriate thing. So I would say, and then use the systems that are provided from the hospitals and stuff, because those are good things, like the night breathing things, the cough assist, those definitely help. So.
Sure. So I live alone currently, and I do have, I'm fortunate enough to have family close by, a lot of family. So for me, I have grandparents that are very helpful. So usually in the mornings, my grandpa helps me. And then in the evenings, either my dad is helping me with showers, or if it's not a shower night, then I have a neighbor kid who also is very willing to help me pretty much whenever, if he's around. So that's been very helpful, and that's been more of a recent kind of addition to my support team. As far as like home modifications go, I don't know if anybody has one good answer, just because of the variability in your house and your situation. And there's just a lot of factors, but I would say the one thing that helps me is just knowing that you may not have all the answers in one day. So it's going to be a process, but as long as you can kind of improve little by little every day, then maybe you can get to a process or something that works good for you.
Do you guys have any smart devices in your home that help you guys?
So
Any devices that you use that do help you live independently?
So I do have an Amazon Alexa and smart thermostat, so that's helpful to talk to Alexa if you want to call somebody and you're on the floor. It will not dial 911. I've tried it. It will not do it. So
My dad's in charge of the thermostat.
And that Alexa can also be a nightmare because, you know, they can just say, hey, Alexa, call grandma. And then I'm in the other room and she's just like, I dropped my pencil on the floor. Can you pick it up? And I'm like, come on. But as far as modifications go, what I would add is start early. Ethan didn't have any equipment until about 3 years ago. But on Facebook, you're going to get with other families, and as their children outgrow it or pass on or go to school and need something else, everybody's willing to transfer and pass it down to other people. So we started off with a shower chair very early, and then we got a manual wheelchair, and then we got the electric wheelchair was actually ordered 1.5 years before we needed it. And it didn't get here until we needed it. So do that early. Make sure that you get your prescription from your doctor. Like we wanted a stander on our wheelchair, and the person that was building it refused to do it. I got a prescription from the doctor, and he still refused to do it. So stand your ground. Make sure that you get what you want. Help other families out. They will help you out. Everybody is really good at community. Ethan didn't have a hospital bed, so we went straight from a bed that just had the head and feet, and then we were donated a freedom bed. So if you ever get a chance to get a hold of one of those, take it. Because those, as they get older, will roll them so that they don't get bed sores, and you're not up all night doing it. So, you know, if you get the chance, get the equipment, and then if you don't need it later on, like right now we have 3 Hoyers, and those were just given to us by other people, and so we're going to donate those on to other people. So, you know, just take advantage of anything that you can get, and then help other people online.
Yeah, I would say, based on my experience, obviously, takes time to get things. So it's obviously good to start early, so I'd say that. So.
Tucker, have you made anything with your 3D printer that helps you?
shower curtain hooks.
That's cool.
The ones I had kept getting tangled, so.
See, that's helpful. Does anybody else have any questions? Yeah? Yeah, come on. I'm going to repeat it anyway.
Yeah. So the thing is that these kids are really, lucky kids. They teach us so many things. But the families struggle so much, and I'm the person who came in this great country, almost from India, for my son, in 2018. And I struggle here so much, that to found anything
So what I want to say to one of the things you said is, you had mentioned like, why doesn't the doctor have a list of things that you need, right? But I think as me in my role as an advocacy representative, I don't represent the clinic. So what I will say is there are so many different vendors, there are so many different options, and there are so many different stories, and there are so many different, like you could have a child who walks until they're 15, you could have a child who loses mobility at the age of 7. But my point is I don't think it would be fair or appropriate necessarily for a doctor to give you that list because they don't necessarily know. I mean, I think that there are so many different insurance plans and there are so many different options that I think in general, in this community, I don't think you're alone in that concern, and I don't think that you're alone in that situation. It is expensive to have healthcare is expensive in general, and it is expensive to have a disability or have a child with a disability. And while I wish that things were different in that aspect, unfortunately it's not. So And I hear you, but I also think that what you also have to consider is how many patients they're seeing and that they are doing their best to provide the best care and the best options to you. So I think we also have to look at it like, from what I have seen, University of Iowa does a really good job, and you actually, in this area, have better care than other areas in the country. So I think you also have to look at it from that perspective as well. But we could talk about this all day, but I do want to know if you have a question for them that you want to ask. Yeah. So what modifications in your home have you found help you most in terms of mobility? So he mentioned the zero entry shower or bathroom, excuse me. So what other modifications in your home do you feel help allow you to be more independent in your home in both situations?
Well, I could speak on that. We had to, unfortunately, build a new home, but we were fortunate to able to do that, and we just planned everything out for needs that, obviously you're not going to know every need in the future. That way, saying to your doctor, we're noticing this happening, then I think it's definitely easy for doctors to understand, okay, we need to start thinking about, a wheelchair, right? Or obviously the lift, shower chair and wheelchair are great things. I had to start with a manual chair because I was still kind of walking, but I was able to get that, so that's great. And if you get a power chair, it's great because obviously get more independence with that. So
I would say wider doors, so it's easier for the wheelchair to go through. Lower, like, light switches, so if you're in the wheelchair, you can reach them easier, or some kind of smart lights that you can talk to them and they turn on. And then, obviously, like, a single level home is best, and limit the amount of steps, because any step, then you need either a ramp or a lift, and they each have their own pros and cons. I mean, a ramp outside, well, you got to shovel the snow off of it, but you know, a lift outside is, depending on how many steps you have, might take a long time to get you between different levels, and if it's cold outside or raining, that's not fun. So there's not really a one-size-fits-all
Right,
answer,
there isn't.
unfortunately.
My suggestion is to widen your doorways, if you
Yes.
can. We're not able to in our house because of the way the structured beams are. Take the cabinet. How do you navigate that? We have lots of scuffs under our doors. So now we are taking the one bathroom that we can widen. It's a half bath with my utility room. So we're widening that door. We're taking the cabinet out from underneath the sink so that he can pull up to it, brush his teeth. The bathroom situation, we actually did ourselves. Took the standing shower out, widened it to 6 feet long, and then we just have a little tiny lip that we have to pull his chair over. But they gave us there's little rubber ledges that you can put up, so you don't have to do that lift. What else? Definitely have some kind of, even if, like, when we first got ours, we didn't have anything, so I went on Amazon and I paid $600 for a lift that we can fold up and take with us on vacation. Now, if anybody is getting ready to get a lift, ask for the Mo lift. They are wonderful. They're electric. They fold up. They're on wheels. You roll it right back into your car, and you can take it anywhere. It's the most wonderful thing ever. It's called a Mo Lift 500 or 150.
I have one thing to say to that.
Yes.
So she says it's amazing, but we have someone else, Jessica, who says she doesn't want to take the time for the electric to go up and down, so she still uses a manual. So when you're considering different lift options, think about what you need it for and the time you might want it to take. But the Mo lift is a good option, but just consider your needs.
Well, and I haven't gotten that Mo lift yet, but I hear that it's wonderful. But the one that I got on Amazon came with a hand crank in the front so that you can lift it up and down, and it's got seat belts that latch in. And we took the crank off because, number one, his chest was too big and the crank was going to hit him. So we took a battery-operated drill, and we I mean, it goes up and down really quick. So modify it to yourself. You know,
You can do that. But since we're here, do that safely. Think about that before you do it. And try to work with your physical therapist to see what modifications you might be able to make to the equipment that you have to meet the needs of your child. Because I think, you know, something that we're speaking about, right, is that everybody is so different that a certain modification, like, you know, it's hitting his chest, so they made that modification, but there might be something else you need for your child as well. And we're not recommending anything that might harm your child. So I'm not saying it will, I'm just saying, I don't know.
And everyone should have a perfect lift in their home. We have a jet mom that she invented it for her own son. They're very inexpensive, they're washable, they can go in the pool, and it only takes 2 people. Yeah, yes. No, it's called the Perfect Lift. And they're like $150. And we've got 3 of them. We keep one at my daughter's for her pool, we keep one at his mom's house, we keep one at our house, so that, and we actually used it at the doctor's office the other day because they want him up on the machine to do his scans, and you don't want to trust people lifting them anymore. So we keep it underneath him in the wheelchair, and then it has handles on it, and you just lift him up and put him on the table. So that's, I mean, they've got other ones out there, but this was a Jet Mom that actually.
For sure, I want everyone, when you're talking about equipment, you can purchase things on your own, out of your own pocket, but if you're going to think you're using your insurance benefits or your Medicaid benefits, you need to talk with the vendor and your physical therapist or occupational therapist to determine if what you're wanting is a covered item, because there can be a lot of frustration if you go through this process and that is not something that they're willing to pay for. And then secondly, even in terms of like leaving a lift underneath you while you're staying in the chair, for those of you at risk for skin breakdown, having something underneath you besides your special cushions can lead to skin breakdown. So there are so many nuances. We could be here for 5 years and talk about many of them. So talk about the pros and cons with somebody who has a lot of experience. Sometimes that is another family, but your therapist at your clinics or wherever you go, even in your community, might have some ideas about pros and cons of some of these things.
Any other questions? All right, well, if you do have any other questions for anybody up here, please go ahead and catch them at another time, but we will go ahead and start our pharma presentations.